A very good morning to one and all gathered here on this virtual platform for this continuing medical education on CBME in pharmacology, a roadmap for effective implementation. On behalf of Department of Pharmacology, KS Hegde Medical Academy, Mangalore, we would like to extend a very warm welcome to all of you. I am Dr. Biasan Babu, Associate Professor in Pharmacology, SHEMA, and my colleague Dr. Swati Acharya, Associate Professor, Department of Pharmacology, SHEMA, will be the MCs for today's program. We, the Department of Pharmacology, SHEMA, have lined up for you a fruitful and engaging academic session. Hope you will all enjoy it. We will start the CME by a session on interactive large group teaching. In the current curriculum-based medical education of pharmacology, there is a great reduction from 120 hours to 80 hours, which is really a challenge for us to implement. It will be interesting to have this 80 hours of large group teaching, an interactive one. We have with us today Dr. Rakhi Tripathi, an eminent pharmacologist and medical educationist from St. G.S. Medical College, to share her experience with all of us. Dr. Rakhi Tripathi is Associate Professor in Pharmacology, St. G.S. Medical College and KEM Hospital. She has a teaching experience of more than 20 years. She has conducted more than 30 clinical trials and studies. She is an approved speaker by MUHS for Research Methodology Workshop and NMC approved revised and advanced courses in medical education. She has more than 50 publications in national and international journals. She is a member of MUHS Task Force for Phase 2 CBME implementation. And she is an invited expert by ICMR for drafting national ethical guidelines for biomedical and health research involving human participants. Ma'am, over to you, please.
Okay, good morning to the organizers of SHEMA, Department of Pharmacology, to give me this opportunity. A very good morning to all the participants who have registered for this course, and even all my co-faculty and eminent pharmacologists who are there present today. A very good morning to all of you. And as the organizers have rightly said that at one time pharmacology was 1.5 years, we had some 120 plus lectures to take, and now this has been reduced to 80 lectures. As it was stated, NMC has rightly put that it's no longer the word didactic is used. Even if you go to the NMC document, okay, it does not it does not use the word didactic. It uses the word large interactive session. So now all of us have to get well versed to large interactive sessions. So what I hope to take you through this 40 minutes is a bird's eye view on understanding the concept of interactive teaching, state the methods and softwares for interactivity, familiarize with selective interactive techniques in the large group, and we will also try to discuss the session plan for interactive sessions that we intend to take for large group sessions. Now, what is a large group? If I tell anybody to write in the chat box, can you just write the numbers in the chat box? Whenever you say large group means what number flashes in front of your mind? You may just write in the chat box. We will just glance through that. Whoever feels like. Okay. Are any numbers coming in the chat box? Okay, so as you are putting up in the chat box, okay, as I think so Anna Malai, the participant has answered anything above 25. All of you are right. If you go by the Western literature and by the definition, any number above 25 becomes large group. Okay, but whereas in Indian context, when we talk large group, we are talking typical our big batch lectures which we are going to take for the whole class at one go. So obviously the number is going to be somewhere beyond 100, 150, 200, 250. So in our minds, large group, we are looking speaking of that large group. Whereas if you go by definition, large group was just meeting something by 25. In fact, when we say 25, 30, we are still taking practical sessions, and we still call all that a small group. Okay, so the point is that even when I am talking about large group, it is basically going to be a bigger audience. It is something like this picture. Okay, teacher is there and the whole class is full, and you and me are standing there to take the lecture to be there. Okay, now obviously all our large group sessions usually would go into the lecture format. Sometimes there may be student symposiums, student seminars, or we may organize panel discussion, or there may be team teaching, 2 or 3 teachers coming together and taking that topic for the entire class that is there. And all of you must be well versed with this definition of lecture also, that it was an uninterrupted rambling exposition of apparently trivial information delivered in a sleep inducing monotone for 1 hour. So this obviously you and me don't want to do. We no longer as facilitators or as teachers want to talk something where students are going to put off to sleep. And this is what is the picture of that big batch lecture that we talk. Either students are sleeping, they are completing their journal work, they are on their mobile, they may do so it's not that everybody, the entire audience is just not with you. Okay, you and me are taking the lecture with all our efforts, but the student is in some different planet and totally not interested. And then comes the point, okay, what is the solution for this? Was interactivity the solution to this? So when we say that we are going to do interactive teaching, so what do we mean that we are going to do? So with the moment we utter, this is the simplest definition of interactivity that I have picked up. Whenever we say interactive teaching, it means that you are giving students something to do. That do could either be something in action or something you tell them to think. Okay, you collect back information on what they have done and then go forward to do what is the next step. Okay, so most of the teachers do this. Is there something beyond that? Most of the time when we are taking our lecture, in between we may try to break the monotony, we may crack a joke, we may put in some question, we may ask them something to some MCQ to answer. All these things we are trying our level best to do, but let us see if we can walk that extra step further. Okay, so now just I want you to answer in your chat box that if this was interactivity, okay, basic definition of interactivity. Have you attempted interactivity in your session? I mean any session, large group, small group, what is your answer? I'm expecting most of you to write answer yes, but still let us see in the chat box. What are you answering? Okay, so as most of you are coming up in the box, most of you are writing yes. So that has made the session more easy. It's not that the concept is new or you and me are not aware about its importance. Okay, so just to reinforce that, remember that whenever we are taking a lecture, the so-called lecture session, obviously you and me are aware that telling is not teaching and neither is listening learning. Just because I am saying something, you are listening to me and therefore you are learning, that is no way being true. Okay, at the same time we have to do something in the lecture so that we critically stimulate the mental processing of the students. At the same time in our lecture we are able to motivate that student, okay, to give a response so that we can provide immediate feedback. And when we try to introduce interactivity in our session, we somehow try to create a safe environment because we are expecting students to participate in that, and therefore the students also feel comfortable and they participate. So that is where is the purpose of interactivity. So whenever we are saying we are doing interactivity, it's a prerequisite that you have, when you are there in the classroom, it's a non-threatening safe environment for the student to participate. Okay, obviously interactive teaching is going to involve active engagement of the students. So there is student, there is teacher, there are students, there is content. All this has to form in a proper grid. And obviously interactivity would help us to go to a higher level of concept clarity, better retention, and because of interactivity, we could demonstrate real world applications, especially in context of pharmacology. Okay, so when you are putting up a case, you are talking about applied pharmacology of that topic. Okay, scientifically also it has been proven that interactivity, if you introduce in your lectures, students are going to benefit. Okay, so as shown over here, the students, those who are with interactivity, they have better retention of knowledge. Now, being pharmacologist forum, obviously we are, all of us are very good in classification, and very typical starting of any session, we put classification. So over here also, I try to attempt the same thing. There is classification even of interactive techniques. Now, there are certain techniques when we use interactivity is inbuilt. So inbuilt, I mean to say is that if I am using any of these teaching learning methods, automatically interactivity is inbuilt. So if I was talking about a flipped classroom, if I'm saying I'm going to take a session as flipped classroom, obviously interactivity will come in between, because obviously I will give some resource material, students will read, then I will want them to come to the bigger classroom and discuss, and they will put forth their opinions. So there will be interactivity. Same thing would hold good for problem-based learning, case-based learning, role play, video assisted learning that we are trying to do in our bigger classrooms. Now, when we want to talk about built-in means we are going to our traditional conventional lecture setting. Okay, so it's an offline or be it online, that lecture setting we are in. So there we may have to take attempts to built-in interactivity. And the built-in interactivity strategies, I have listed very few. There are multiple papers where if you Google, which will tell you 101 interactive strategies, somebody will tell you 200 interactive, somebody will give you 51. So there are a lot of strategies which are there in the literature. It all depends with which strategy as a teacher you and me are comfortable with, and which we can execute in our class in very, very unstressful manner. That is very important. Okay, so obviously, as I was saying, built-in techniques, most common being questioning, think, pair, share, quick things, 1 minute paper, jigsaw, buzz groups, brainstorming. These are all the built-in techniques that are there. Now, today we are taking all online lectures because of COVID pandemic. When we are taking online lectures also, all these options to do interactivity are available. Okay, whichever video conferencing platform we are using, if you and me are the host, okay, so poll is already there, poll option is there. Okay, as most of you have already written. So that option is there. You can put an MCQ, you can put in the options, students can answer. It is a live poll. It is typical like that, Kaun Banega Karodpati. You see the options coming up, student is happy, you are happy. You can gauge where everything is. Breakout rooms are there, similarly way as you would have physically done breakout rooms. Chat box as you are now answering, okay, where I can get an idea that most of you is a learned audience. I don't have to talk much. Okay, that you can also do sharing of assignments, Google Forms, Google links in chat box. Okay, so all that can be done. Okay, now there are even these game-based learning apps. Most of these apps, there is a free version also and there is a paid version also. So majority of the teachers use the free version. You can tell the students to download these apps. Okay, these apps can be used in your online session also, as well as in your offline. I think majority of you would have used Kahoot at some point of time. Kahoot is very easy. You can put in all your MCQs. Students also will answer those MCQs individually in your class, and immediately the message comes if the answer is correct, answer is wrong. As a teacher, you also come to know how many students are answering correct or wrong. All that is available to you. At the same time, you also have this quiz, Quizlet Live, Factile, Socrates, Slido, GoSep Box. All these other what should I say, apps are also available. And you could another part is that all these apps, they have a free tutorial. So when you can go through the tutorial and really see it, how it is to be used. Many of them also give you MCQ templates. So it is easy to type and it goes at 1 second, it goes to all the students, and all this can be used even during your offline or your online session. The only requirement for this is that the students should be carrying their mobiles. Now, many of the institutes do permit mobiles in classrooms, but there are certain institutes which may not permit. So if there are phone jammers and all fitted in the classroom, then maybe these apps and all may not work. But otherwise, it's quite this to work even with these apps also. Okay. Now the next question to all of you is that, have you used any of the following techniques for your large group teaching? I want you just to write the options. So either A, B, C, or D. If you have used all, you may be free enough to write even A, B, C, D also. So just 1 minute and let us see. I'm hoping that majority of you must have used something or the other. So in the chat box, you could either write A, B, C, or D. You can have even multiple options. You may write A, C, A, B, D, C, whatever you feel like. Have you used any of these things? Okay, I think majority of you are going with B and C. Okay, which is very the common strategy. Majority times in pharmacology, whenever we have any topic, like say be it hypertension, most of us would begin the lecture with a case. We would have a paper-based case. Most of us may take even the real case from the hospital. Okay, and show that put that case and make the student think, ask questions, and then introduce the drugs. Okay, many of us may make students do role play, or we may show an encounter as video assisted. So these are the common things that are there. Flipped classroom is something which would require a bit more effort from us. Okay, wherein we may, as a prerequisite before the session, we share the resources, make the students go do some pre-classroom or pre-lecture homework. Okay, and then we may ask them to come up with their doubts, clarify their doubts, and then take the level ahead. So that was flipped classroom. And gaming apps, as I told you in the offline, for gaming apps, remember, as a teacher, you and me also have to be well versed with it. Remember, students are very well versed with these apps, because don't forget that we are dealing with students who are very good in playing video games on the internet. So they will be much tech savvy than you and me. So the homework or the training is required actually for us. Students will get very well versed when you put these things on the apps. They will answer immediately. They will put in the questions. They will put in the options. All this is real fun. Okay. Now, going ahead with, since most of you have this idea, so going ahead, these activities which we plan to do in our sessions, they could be individual based. Individual based means we are giving the activity for every student to do, or it could be group based, or there could be observer based. Now, many times when you're doing role plays and all in your session, remember, majority of your class is observer. Observing is also an activity. The point as a teacher, what you and me have to do is we have to guide that observation. We have to facilitate that observation. So maybe we will have to tell the students what to observe. We may share observer checklists with the students, so they are very focused in what to see. Like I remember when we were doing a role play on communication for the drug. It was iron tablet communication for anemia student, and there was a role play going on, and students were told to observe. Okay, so it so happened that when we did debriefing, I was expecting students to answer something pertaining to iron and what side effects did they tell, yeah, correct, not correct. But the student, one or two students commented that, oh, the doctor came late to the OPD and therefore the patient was disgusted. I agree, the point was very valid, but it did focus on the ethical behavior and professionalism, but I had gone with the focus of pharmacology content. So this does happen. So when we are wanting students to observe, we have to be very clear what we want to observe. So we may have to do something called as guided observations, or also provide observer checklist to the students. Okay, so the purposeful questioning, a very important tool that you and me can use when we are taking our big batch lectures. Okay, so obviously the question could be put in beginning of the lecture, Questions could be put in between the lectures as I am doing just now. Okay, so strategic positioning of the questions is very important. And from the questions, obviously, as a teacher, as a facilitator, you can get idea about the audience. Okay, like as I am getting an idea that most of you know most of the concepts. What I am talking is more like a revision, more like a refresher course for most of you. Okay, the questions that you are putting, they could be open-ended or they may be closed. They may be MCQ type, they may be short answers. MCQs also can be simple MCQs to high-end MCQs of comprehension, analysis, evaluation. You could go up to the Bloom's taxonomy depending upon the content that you are teaching and where your students are. You could so you could go on increasing the difficulty level. You could similarly go from low to high order thinking type of questions or MCQs, mini case. You could put mini cases, you could put drug autobiographies, you could put questions as single, you could put questions as multi-tiered. You have put up a drug autobiography and you put in the first clue. Students don't answer, put in the second clue. So those are those multi-tiered questions. Okay, so this way your questioning skill or purposeful questioning skill, as it said, is very, very important. Questioning skill is something that a teacher also needs to develop. So whenever we are trying to put questions, just do a homework, think of what questions you would put up, put those questions in your PPT and be ready for the fun. Now, along with questioning, there is something called as bouncing and scening also, or scene setting that we can do. Bouncing is nothing but bouncing the answers. Okay, student will give the answer and then suppose the student gives a wrong answer or correct answer, then we are very happy. We tell the student very good, but student gives somewhat partly correct answer, then try to bounce that question. Okay, it's like this. Ravi, what do you think of Sakshi's answer? Sakshi, could you further elaborate on what Ravi has said? Or you may ask the third person, Ameya, could you sum up the answers that these two have said? So this is what we call as bouncing answers, which could go hand in hand with the questions that you are putting. So students also know, if teacher has picked up that Ravi, so now teacher will not ask me, no. But when they are aware that the teacher could also go and ask other students also, so majority of them then stay alert. Okay, similarly, you could do scene setting. The question is there. Okay, you had put up a very simple question. You could go on discussing and make from the simple answers that students are giving. You could raise the bar. Like most of you just now had answered role play and case-based learning. If the time was permitting and if I had planned it, I could have raised the bar and asked, okay, when you did role plays, what were the prerequisites for role play? How did you go about doing? What training did you give to your students? Something like that. So similarly, when the scene is there, you have put a very simple aspect. At the same time, you could make it go higher if students are answering correctly. Okay, so that was scene setting. The other thing that could go at individual level is something called as concept test. Now over here also it's a question or an MCQ, okay, which is based on a concept finding. The main idea is you're trying to look at clarification of concepts. And again, the same way, if less than 30 people answer it correctly, you may have to reteach, revisit. If majority are answering correctly, it is just by peer discussion and you may take revote. Most of them have answered correctly, then you have to go on to the next topic. So obviously that gives you a clarity about where your student audience is. Similarly, you could have something called as quick thinks. Okay, quick things means is that you just flash in a statement or a question and make student think. It would be something like this: correct the error. NTG stimulates adenyl cyclase, hence vasodilatation. You may just ask the students, is this statement correct? Students some may say yes, some may say no, it is not adenyl, it is guanyl cyclase. And the mediator over there is cyclic GMP. Similarly, you could tell students to reorder, like anaphylactic shock. Which is the sequence of injections are you going to give? Just rearrange these injections that you want. So this way you could ask the students anything. These are quick things: correct the error, reorder the steps, complete the sentence. Okay, where you could ask the student, and student you may either make them write and you may pick up one person to say, or you may, if it's an online thing, you may make everybody write in the chat box. Okay, then there is something called as 1 minute paper. Now 1 minute paper, you may distribute this paper at the end of your session and ask what is the important thing that you have learned. Just write that important point. Or if there are any burning questions, just write that question. Or if there is any confusing aspect you have not understood, what is called as a muddiest point, just write that, and you may collect these papers. Okay, so if it was a class of 250, then I have distributed this 250 papers to them, okay, which is 1 minute paper. I do not have that much time, then I can also go to very simple technique called as thumbs up. At the end of my session or in between the session, I can tell the students, if you have understood, show a thumbs up. Not understood, sort of, thumbs halfway. You have not understood at all, thumbs down. Now this, when I take session, students are so used to this thumbs up that even before I tell them, some students straight away, you know, they put thumbs down if they are not understanding. So 1 minute paper, you don't want to spend time in printing, and this, even this small gestures, non-verbal gestures also can add, can, you know, put up that interactivity. You may use this way colored papers. Okay, just have these colored papers, green, yellow, and red. All these are very, very much available in the bookstores. Okay, there you get these small chits, colored chits, and you may just distribute to the students and just tell them to flash that color paper. Accordingly, again, you can understand whether they have understood or they are not understanding. Okay, coming to group things, think, pair, share, a very common strategy. As the students are thinking, you tell them, okay, just talk with your neighbor, discuss this question, and then come up with the answer. Similarly, buzz groups, they are sitting. Okay, you may tell them to make groups of this way 3, you may tell them to make groups of 4, 6 with the adjacent rows, and buzz groups are made. When they are discussing, students are discussing, that buzz sound comes, and therefore buzz group. Think, pair, share, and buzz group. In these techniques, you don't have to waste time in making groups, those pre-planning groups and all that. You need not, you may just go and do it that way. Okay, there is jigsaw, where in this case already groups are there. There are groups already made in your class. You have made those groups which are there. Okay, pre-planned groups are there. Now suddenly you tell few members of one group to go and join the other group. Similarly, this way you keep on intermingling the students from each group. So that is how students move from one group to the other. They discuss the question that you have given them, and then they go back to the parent group. So when they go back to their parent group, every group student who had left the parent group now is returning back with a new information, and they will discuss back to their home group. So this is jigsaw. Okay, this is how you could go on. This jigsaw has many, call it even syndicates. You can this way use this jigsaw and even go up and build up what is called as pyramids. You can use all these strategies in your large group sessions also. Okay. Now, there are additional things which are done. Okay, as you may trigger something, you may put, as said, you may put a case history, as most of you have said. You may give some group task. You may put a film in between. You may put a published article abstract and make them read and think about it. You may make students draw a concept map. You have discussed all the antihypertensive drugs in your session. You may tell them, okay, now draw the target sites of all the antihypertensive drugs on the sympathetic nervous system, or draw all the analgesics on the pain pathway. And students beautifully draw, and then you can exchange, you can show it to their other friends and go about doing it. Okay, you could also organize in your large group debates. You can organize peer tutoring. You can organize panel discussion, plenary sessions. Remember, when you and me are doing this, that means that time student is taking the role of that teacher. You are and me are just like a backbencher. We have to just see that students are doing what we have instructed them to do. So these are all the other strategies also which could be done in large group. Okay, now comes the question, okay, we have spoken so much about something about interactivity. Most of you are using it. Everybody is convinced about its benefit effects also. Now, what are your concerns? Just take a time, and whichever option you think, you may again give multiple options over here also, and you may write this down in the chat box. What are your concerns? Any concerns are there, or everybody is happy with that interactivity? Everybody is happy. Okay, I have to talk my content and in between do this interactivity also. Any option? This very few are writing, so I am hoping. I think majority of you have no concerns. Okay, answers are coming up. Great. Okay, I think most of you are thinking on these lines. Okay, there is no time to do it. I agree. It's most of times it is a 40-minute lecture, or it's a 45-minute lecture, or it may be 1 hour. And there is and pharmacology, the portion is vast and it is quite intense. This that we have to teach. Where is the time to do all this? Okay, so most of us may be concerned that there is no time, and most of us would be bothered that content will left undelivered. So these are the concerns, and your concerns are absolutely right. It's there. So if I do these activities, how will I cover all the material? Will be the burning question when we start thinking of interactivity. But the answer to this is that even if I do not do interactivity, just think, just introspect. When you and me are taking a session, majority of the times we are never ever able to cover the entire content. Okay, so remember that giving the entire content, suppose if there are 100 points in Goodman-Gilman textbook on that topic, you and me cannot anytime cover those 100 points. You and me will be going in the lecture only with 20 points. Okay, the more important crucial points which are there, those 20 points also sometimes we are not able to cover, and we may deliver only 15 points. You and me have to accept this fact that we can never cover the entire content in that session, and that is not our duty also. We have to give the salient points, try to cover the salient points. Even if it is not covered, do not panic, do not bother. Let us see how we will go about doing it. So covering the content should not bring you down or boggle you down with not doing interactivity. Okay, so there were all these problems with interactivity. One teacher problem we spoke is the content. The content is left behind. Now, even when we are doing interactivity, okay, sometimes, or when you're doing, whole group is silent and unresponsive. Students don't talk. We are thinking students are bubbling and they are going to answer. And when you put up the question, nobody is, the whole class is quiet. Okay, or they are not attentive, they are doing their own activities. Okay, even when you do think, pair, share, students are discussing their own thing. They are discussing, okay, when they will get a break in canteen, what they will do, when they are discussing something else. They are not discussing your question of why adrenaline is an anaphylactic shock. Okay, disturbances can be there, distractions are there. Okay, lot of things are there. Now, what is the solution? How to solve all this? To solve all this, okay, you and me have to plan the session in advance. Some homework we will have to do. Okay, we will have to set up the ground rules and talk to students. So whenever you are beginning the session, tell the students in the beginning, okay, today's session is a large interactive session. I'm going to today take a session on anti-epileptics. Okay, tell them in the beginning only your session plan. Okay, I would be talking for some 15 minutes. After that, there will be some interactivity in which interactivity I hope you to participate for 10 minutes. After that, we will do a debriefing session. And again, there will be an interactivity and we will take the discussion if time permits. Something like this opening statement I have made in the class in the beginning itself. Okay, and use interactive techniques, start doing it with using questions. Rather than on the first set itself, you go to jigsaw or brainstorming or debates. Start making use of questions in your sessions, and make a habit of celebrating the small wins. When I say celebrate small wins, I'm not talking about giving students big gifts and all. If student answers correctly, give a small eclair, give one small gems, give one small Cadbury which is coming of 5 rupees. Okay, if it's a difficult question, the person gets 5 star of 10 rupees in the class. Students also know it is a very small token that you are appreciating their effort, you are appreciating their correct answer. And then students get into that. Then there are students who will tell, okay, even I should get an eclair. Even if you distribute eclair to all 250 students, or you distribute Alpenlebe, that it is quite cost effective. Okay, and students also enjoy. They will enjoy that small wins. Or if you are using those gaming apps and all, you get those, those winning messages. Awesome, you are the winner. You may also give these small cards, or you may flash on the PPT also. Okay, you may ask the student's name and put the name and say, awesome, today Ameya has answered this question. So students that way get involved, because you are celebrating, you are appreciating those small wins. Okay, never try to punish that individual. If students don't answer, don't tell this way, okay, you are not attentive, now go out of the class. No, you may at the most tell them to punish the act. Students may, there is somebody has put in the message, students are not cooperating. I agree with you, sir, but you have to put the question, take the students in your side. You may do a simple thing. You may call some 10 or 15 students of your class before the lecture. Today everything is digital, so it's not that you cannot contact the students. So you may call, you may have many times your tutorial batches which are there with you. You may call those tutorial batch students to begin with. They are attending that big batch lecture, and you may tell them, okay, I'm going to ask these MCQs. Okay, and these are the MCQs. You may even share the MCQs with them in advance. Tell them to find out the answer, and you put that in the big class. Ask those students of your batch only to answer. Definitely they will answer, or they will make a mistake or whatever. And even appreciate even when students are getting up and answering, even if they have answered wrong. Okay, when you start appreciating, giving them then that positive feedback, they will then get involved and they will get engaged. Because students, mainly in Indian context, they are scared. Even you and me are scared of talking. You and me are sometimes scared, even when we are attending these online conferences, when the speaker tells, put the doubt in chat box. Sometimes you and me start thinking, if I put this doubt, will I look ignorant? Will I look something very, not in the board? What people will think about me? So this sort of complex inhibitions are there. We have to take efforts to make students come out of it. So when they are trying to come out, appreciate. Even if they are giving wrong answers, appreciate, okay, that was a good attempt from you. Okay, but I'm sorry, this is the wrong answer, but give them some hints. See if the student is catching up. Okay, so try to do all that. So we have to plan for this engagement. Okay, obviously look at the number, look at the time, look at the rooms which are available. Okay, choose a purposeful interactive strategy. Okay, so whatever strategy you want to stir this, look whether you want it for concept teaching or for sharing ideas, or you want to make students do something, you want to internalize, or you want to just test their knowledge. The way just now I am putting questions and all of you are answering fabulously well. And accordingly, you can plan the variety of activities. Whenever you are doing the activity, see that you are giving the rationale for that activity. You are giving the instructions very clearly. You may have to email these instructions beforehand to them. You may WhatsApp to them, and then you have to even debrief the key points. Okay, so very important thing for you and me is to make this session plan. This session plan, you and me, this homework, you and me have to do. This must be a picture that most of you must have seen. Okay, so this is a session plan. Okay, when am I going? What am I going to do? This is a template session plan. I have given the session objectives. I'll put up a case. I have put the time factor. Okay, this was the session plan that I did for my anti-epileptic session. Okay, initial sessions are in the morning. So 10 minutes I was going to give the classification, explain mechanism of all anti-epileptic drugs. And then I had students to present drug information on these 7 drugs. Then there was an MCQ round, which was also designed by students only. They were asking MCQ and the remaining students had to answer. Then I had to debrief, and I had given an assignment to all of them to visit the neurology OPD as and when time permits and look at the drug therapy given to for an epileptic patient. What planning I had to do? I had to do this planning. We have a batch of 250. Okay, I had jotted down these roll numbers. There were students, 5 students each, where I had called and I had allotted them 1 drug. So I had called roll numbers 1 to 5. Okay, they had to prepare a PPT on phenytoin, 3 slides. I had given them even the slide template on what, and they had to fit in that information. They were going to show me the PPT. I was going to review that. Similarly, I had made a batch of 5 students each to prepare even MCQ on that one drug only. So even this MCQ group was also preparing 1 or 2 MCQ on only one drug. It's not big. It's what was not a big section for them. All these students, I had made them sit in the initial rows, initial 7 rows, and the remaining class was behind. So I knew that I had to ask questions from the remaining class. So all this effort I had to do, and I had to execute the session. Remember that whenever we are taking a large group session, information is what we are trying to do. We have to influence, trigger the student interest so that they go back and read the topic. So main aim of ours is to inspire the student regarding the topic that we are teaching or we are talking. Even if the content is left behind, do not bother. At the end of the session, you can always tell, okay, I had even planned to do adverse effects of anti-epileptics. Because of this interactivity, we have lost time. I'm sharing with you the slides on the adverse events of anti-epileptic. Please go through that. If you have any questions, please put that in the email me, or in the next lecture, I will take up these questions for the first 10 minutes. So even if your content which you had planned is left behind, make this, tell that, okay, this is left behind, this is important. Tell them the resources, tell them what to read, share with them, engage them in and see that they own their own reading and their leadership. Okay, acknowledgement obviously to my mentor Rege madam. Okay, and this is the last slide, and a big thank you. Okay, so remember that our focus has to be student learning, and interactivity is always a means towards that greater learning. Okay, so once again, a heartfelt thanks to the lovely audience who's been with me, and the organizers who have given me this opportunity. Any questions in the chat box? I think as the questions were coming, I've tried to answer them. Do you still have any concerns? Then my email is there with the organizers. You can email that, and I would answer on the. Okay. Shujat has asked to punish the act. Punish the act means, like, say for example, the student has put a correct answer, has put a totally incorrect answer. Then you may ask them, okay, see Ravi, you have answered this. This answer is wrong. Why do you think did you give this wrong answer? Did you not read up the topic? The student may tell, I've not read up the topic. Okay, so next time, can you read up the topic and come? Next time, would you able to answer the same question? Or you may also call him outside the class and ask him why. Sometimes students tell, okay, we read pharmacology, but we forget. So maybe you will have to, counsel him in how to, read pharmacology and make pharmacology interesting and do this. So that is punishing the act, not the student. Student punishing is that, okay, if you are not answering, you go out of the class, or I will give you a memo, or I will jot down this in the logbook, or I will report this to your parent. No, don't go to such strategies. Okay. Any other thing I am not seeing? I think somebody has asked me, would you share the PPT? So the answer from my side is yes. I've already shared this with sir also.
Circulated all the delegates.
Okay, ma'am. Ma'am, over to you.
For sharing your experience with us in short span of time. Hope the delegates have really benefited by the sessions and start practicing interactive large group sessions. And now we'll have the formal inauguration of CME in 2 minutes.
Ma'am, I will stop share. Okay.
Sure.
Yes.
Now we'll have the formal inauguration of CME. For the inauguration function, we have our beloved Vice Chancellor, Dr. Satish Kumar Bandari, sir, and Vice Dean Administration, Dr. Jayaprakash Shetty, sir, with us. Before we start, prayer purifies our mind and takes away negativity. Light is a pretty universal symbol of truth, knowledge, and understanding. So we start our inaugural function with the lighting lamp prayer.
Problem ఉండదండి.
Now, I request Dr. Rajendra Hulla, Professor and Head, Department of Pharmacology, to welcome the dignitaries and the audience.
On behalf of the Pharmacology Department, very good morning to all. Happy to mention that our department is organizing the online CME, CBME in Pharmacology, a roadmap for research implementation. All of us are aware that about the changing of medical curriculum. From conventional, we are shifting to competence-based medical education. We are all trying to adjust to the new pattern, and definitely we seek the help and support of our colleagues from other institutions. In view of that, this CME has been organized. At the outset, let me welcome our Vice Chancellor, Dr. Satish Kumar Bandari, who has readily agreed to inaugurate this event. I welcome our Dean, Dr. P.S. Prakash, and Vice Deans, Dr. Amrit Rajko and Dr. Jayaprakash Shetty. Warm welcome to all the resource people from premier institutions. Without their support, it would have been possible to organize this CME. I would like to stress here that nearly 400 participants have been registered, and I extend special welcome to all of them. Lastly, I welcome all my departmental and institutional colleagues. I request all of you to actively participate in the CME and enjoy the academic feast. Once again, I extend warm welcome to all of you. Thank you.
Thank you, sir, for that welcome address. Now, I request our chief guest, Dr. Professor Satish Kumar Bandari, Vice Chancellor, Nitte University, and eminent EN surgeon, to deliver the opening remarks. Sir.
Am I audible?
Yes, sir. Yes, sir.
Very good morning. It's my privilege to be part of this CBME in Pharmacology workshop, or CME, organized by the Department of Pharmacology of KSAID Medical Academy. Presiding officer of today's webinar Jayaprakash Shetty, the Vice Dean of the Medical School, the head of the department of Pharmacology department, and other faculty of Pharmacology department, and esteemed distinguished resource persons for this program, Dr. Raki, Dr. Sheetal, Dr. Manikantan, Dr. Ananya, and Dr. Dinesh, and Dr. Nayana, and Dr. Sachidanand Adiga, and Dr. Mangala Rao. It's indeed my privilege to be part of this inaugural function. I should congratulate the Department of Pharmacology for selecting this topic, very appropriate topic. They have selected CBME in Pharmacology, a roadmap for effective implementation. As you all know, now the new curriculum has been introduced in the medical school. There's a famous quote by Winston Churchill: to improve is to change, to be perfect is to change frequently. You all know that the competency-based medical education has been waiting in the wings for quite some time, and it was to be implemented in the year 2019. And I'm very happy to tell you that KSETA Medical Academy is one of the first medical college in the country to get the curriculum to be introduced in the medical school. I congratulate the dean and vice deans for their a tremendous effort which they have put to introduce CBME in the medical school. I'm very happy that things are going very smoothly. And now the pharmacology department also, I think the batch has come to the pharmacology department for the CBME. In the academic year 2019, it is a significant year in the CBME curriculum, because all of a sudden NMC decided to implement CBME in the country. This competency-based medical education was already being practiced in the Western countries in different formats. According to this CBME, Indian medical graduates are finally going to be trained, which will match the quality of education provided by our global counterparts. It is very much pertinent to train our Indian medical graduates to be globally competent and locally relevant to face the routine challenges in the field of healthcare. In this connection, an Indian medical graduate should imbibe the relevant competencies and fulfill the 5 roles he has to play. It is a clinician, leader, professional, communicator, and a lifelong learner. And he has to hone these skills during his training in the medical school. To achieve this, NMC has come out with a wonderful pearls like I understand there is a structured foundation course, early clinical exposure, ADCOM sessions, and certifiable skills. And another very important part is electives, which has been introduced in the medical course. And it has been already, we had a lot of discussion, what are the electives to be given to the medical students. You being particularly the teachers play a very important role in the implementation of the CBME in the medical school, because it's a paradigm shift in the training of Indian medical graduates. And you have got enormous task of implementing this particular curriculum in the medical school. I went through the invite for this webinar, and as I initially talked about the resource person, distinct resource persons from the very distinguished medical schools of the country. I understand there is going to be a series of discussions going to be held in this webinar, and definitely both the young colleagues, young teachers, as the seniors going to be benefited by this webinar. I hope the CME will help particularly our younger colleagues and also the senior colleagues in implementation of the competency-based medical education relevant to pharmacology. I wish great success. I think all of you will have very interactive, fruitful discussion in the whole day, which I think it's going to be organized till, I understand, till 3:30 p.m. and a series of webinar talks by very distinguished faculty. I request all of you to participate very actively and contribute for the success of the webinar. Thank you. Wish you all the best.
Thank you, sir, for your opening remarks. Now I request our presiding officer of today's function, Professor Dr. Jayaprakash Shetty, Vice Dean Administration, Professor and Head Department of Pathology, CBME Medical Academy, to deliver the presidential remarks.
Respected Honorable Vice Chancellor of Nitte deemed to be University, Professor Satish Kumar Bandari, sir. The organizing chairman, Dr. Rajendra Holla, the head of the Department of Pharmacology, organizing secretary, Dr. Sachidanand Adiga, the departmental colleagues from the Department of Pharmacology, very eminent resource persons across India, from Jipmer to Ludhiana to from Mumbai to our own Mangalore, and dear participants. As our Honorable Vice Chancellor has already mentioned, CBME curriculum is a major task from the then Medical Council of India to National Medical Commission to change 75-year-old medical curriculum to shape an Indian medical graduate to a better clinician in the days to come. As our Honorable Vice Chancellor said, when he was the former dean of this medical school, he is the first person before Medical Council of India implement. He brought many changes in implementation of the curriculum. He formed a curriculum committee, probably not to boast of, maybe the first college under his deanship has started the simulation lab. I request the faculty members, when you are free, when you are visiting Mangalore, you can visit. This was his idea to shape the simulation lab in the medical school. And after that has been started, the MCI notified that every medical college should have a skill lab. So these are all the innovative things were thought of in the medical college much earlier. Even when curriculum medical education was implemented under the chairmanship of the Vice Chancellor of Nitte deemed University, we organized the challenges in the curriculum-based medical education across India. What are the challenges before its implementation? Now, the three batches are there in CBME. As our Honorable Vice Chancellor said, there are many goals for us. One is, what was 1.5 years in second year, the pharmacology, pathology, microbiology was taught. Now it is condensed to 1 year. With the COVID pandemic is taking place, it is reduced to 11 months. The challenges are the didactic lectures are taken off and the certified skills are implemented. The competency-based curriculum has been implemented. What was the whole batch of 100, 150 or 250 in the lecture hall has to be taken. Now it is divided into small groups and they're taught in the same subject has been taught in 3 or 4 different groups. So the challenges are to the teachers how to shape these students. At the same time, the teaching faculty, that is one more double-edged weapon. The NMC has modified the curriculum and curriculum-based medical education. The faculty ratio remained the same. The batches of 150 are divided into multiple batches. So these are all the areas the eminent teachers has to touch upon, and in what best way, because gone are those days you prepare a PowerPoint and go to the lecture class and take. You need to modify how a best topic, argument's sake, and antihypertensive drugs are taken, how best it can be taught in a small group teaching. So I think the eminent faculty members will address all the participants, how best they can shape themselves to teach the students, because now that it is more of teacher-centric in shaping the Indian medical graduate. As our Honorable Vice Chancellor already mentioned, the whole idea is he should be a good clinician when he's come out of, he should be a good professional, he should be a good role model when he completes 5.5 years course, including the internship. I hope the roadmap to CBME curriculum, especially with reference to the subject of pharmacology, will be enlightened with all the eminent speakers, and all the participants will go home with the fruitful knowledge to implement in their respective institutions. Thank you once again for giving me an opportunity to preside over the CME. Wish you all the best. Have a nice day.
thank Dr. Satish Kumar Bhandari sir and Dr. Jayaprakash Shetty sir for those inspiring opening remarks and for inaugurating this continued medical education. We hope to receive your support for us facilitators in implementing the same. Now, we shall move on to the next scientific session, small group teaching in pharmacology. With the introduction of CBME, there is a great emphasis on small group teaching in pharmacology. Due to various reasons such as resource constraints in manpower and space, lack of clear guidelines on the same, training students in small group sessions has become a real challenge. It's my privilege to introduce the next speaker of the day, Dr. Sheetal Ullal, to address these issues. Dr. Sheetal Ullal is Professor and Head, Department of Pharmacology, Kasturba Medical College, Mangalore. She has completed her MBBS from Medical College, Baroda, and her MD in Pharmacology from KMC, Mangalore. She has completed her certificate course in bioethics at the Center of Bioethics, Mahe. She has also done her advanced course in medical education. She is a member of Medical Education Unit and co-secretary of the IEC at KMC, Mangalore. She is a chairperson of IEC Vinaya Hospital and Research Center and a member of IEC at Manipal College of Dental Sciences, Mangalore. She has guided many postgraduates and PhD students. She has more than 65 publications in national and international journals to her credit. Her special interests include bioethics, medical education, infectious diseases, and preclinical research in cognition, drug toxicity, and diabetes. I welcome you, ma'am, to this session.
Thank you for the warm welcome. And at the outset, let me thank the head of the department, Molla sir, the organizing secretary, Dr. Adiga, the whole department at Kshema and Nitte University for giving me this opportunity to share my views on this topic. I'll quickly share my screen. Please let me know if it is visible. Is the screen visible?
Yes, ma'am. Yes, ma'am.
Okay. Right. So let us just think about this. Does size really matter? We all talk about the big and the small of things, especially when it comes to taking a class, large group teaching, small group teaching. Does the size really matter? With this little thought-provoking idea, let us begin with small group teaching in pharmacology. What are the necessary requirements? How to go about it? The objectives of this session are that at the end of this session, the participant will identify the appropriate use of small group teaching, indicate the goals of small group teaching, determine the role of the teacher and group dynamics in small group teaching, prepare a plan for a small group teaching, choosing an appropriate method. During the session, if there are any questions, you may put them in the chat box. I can look at it. And if at the end of the session, if I've missed something, I hope the organizers will tell me if there are any questions. Right?
Yes,
Okay. So the outline is just going to be what is small group teaching? Why should we move towards small group teaching apart from the compulsions from NMC? Of course, why even without the compulsions, we should be moving more and more towards small group teaching, and how to go about it. So what basically is a group? Let us just start from the basics. We say large group, small group. What is a group? Is this a group? Anybody in the chat box? Yes, no, quickly. 5 seconds. Is this a group? How many of you agree? Okay. Is something coming on the chat? Because I'm not able to, I can't make out whether somebody is answering or not answering. I'm not getting anything. Anyway, this is a group of people, I would say, or a collection of people waiting for the bus with the name of everybody is waiting for that bus. Everybody is single objective is that they're waiting for a bus. But this does not form a group. A group is a collection of people who interact, not just have the same objective, but they should be interacting. At least for our medical education parlance, let us take a group as somebody who is interacting. Just a bunch of people going together in the lift is not a group. This would be a group. Even if they look like they are arguing on a point, this still is a group because they are interacting. So that essentially is the core of group teaching, that they are all interacting, whether it's a large group or a small group. We try and make sure as moderators that there is some interaction for learning. So now, what is a small group? I have been asked these questions even before the session. That how small is a small group? There are different different literature, medical literature give different answers to this. Different people interpret the small in a different way because small is after all a very relative term. For a batch of 250, even 100 is small. Or if I divide the batch into 125 of 2, even 125 is smaller than the 250. So how small is small? As per literature, a group of 8 to 10 students is a small group. That would be ideal. Most of the literature, which is of course Western literature, when they talk about small group, they're talking about a number of 10 to 12 at the maximum. However, there are articles which have considered even 2 as a group and up to 30 as a group. But when we talk of small group, as has been mentioned, 30 is said to be the limit. And that's why I think even the MCI and later NMC, when we have these revised basic courses and all, they don't take more than 30 in a group. However, it's not the size that matters. Just because you have 31, it doesn't become a large group. For that matter, you can have the same principles in a much larger group. So your small group teaching methods can operate even in a larger setup of 100, say for example, in a lecture. As Madam previously spoke about interaction in a lecture, she gave us so many examples of how to break that larger group into smaller within that space and introduce some interaction. So it's not about the size so much as it is about what we do in that group. How do we initiate that interaction and learning, not just any interaction, but the aim should be the learning that takes place during that interaction. So that makes it important that it's not just about the size, but what exactly happens in the group. Yes, the size does make it easier. When it's a smaller size, it is easier to improve interaction. It is easier to do so many things. So what exactly is small group teaching? Small group teaching is as it looks like in this picture. Of course, the picture does not tell everything about what is going on, but we tend to mistake it as a small group teaching. That teaching is going on in the small group. It is not just about the size. It's not just a lecture in a smaller group. It can be much more than that because the size which is smaller gives us the opportunity of doing so many other things which may be difficult when the number of students is more. So please remember, whenever it's a small group teaching, it is not like a lecture for a smaller number of students. It can be converted into much more than that. So then what is it? It is facilitating participation of a group in an inquiry or a problem solving activity. So there has to be some activity that the student should be doing. It could be a problem solving activity. It would be just questioning the why of or details of what they have already learned in the lecture, or some fresh topic. So it is going into the details so that deeper learning happens. So it is a facilitatory participatory method of teaching in inquiry in problem solving activities. Usually there is a face-to-face interaction. Even if it is online, it has to be a face-to-face interaction. Of course, there are now newer methods where there is no face-to-face interaction and learning in small group happens at different times. So they learn at, however, it has to be planned. The planning of a small group is much more detailed than the planning of a lecture. It is organized. It is not like just a vague discussion or a meandering discussion on that topic. Say I have, madam also spoke about hypertension. So suppose I have a small group teaching on hypertension. It doesn't mean I just walk into the class and we have some vague discussion on hypertension. That would not be the idea. It has to be organized. What all has to be taught? The lesson plan has to be taught, has to be there even for a small group teaching exercise. The most important point is it has to be in a democratic manner. Democratic manner in the sense that has the student should feel totally non-threatened so that they are able to participate. And the most important factor that we tend to forget with small group teaching is that there has to be an SLO, a specific learning objective, minimum one, even for a small group teaching exercise. So we have to plan it accordingly. When we plan our small group teaching classes, we should know which SLO is being dealt with in this class. And then the planning has to start from there. Now, just put up in the chat box, let us just think for about 30 seconds why we know it is difficult. Compared to a lecture, we all think the small group teaching is a little more difficult, or I don't know, there is a little, what should I say, hesitancy to start small group teaching. There has been a lot of resistance when the new CBME came in, or so I think, I don't know. Why should we do small group teaching? Let us just think for 30 seconds and let us put it up in the chat box as to why we need to do small group teaching. Okay, so I have a few answers in the chat box. Most of what you all have said is covered in my next slide. Yes, interaction is much more in a smaller group. In a larger group, it takes an effort, but in a smaller group, it becomes a little more natural because already because of the smaller number, the students feel less threatened. There is more participation, and definitely there is a lot more opportunity to active learning because we can give them more opportunity for participation, which makes active learning a lot more possible. Everybody gets involved. In a large group also, if you have interaction, it's still a small number of students who can interact. Here, much more interaction is possible. So that is why active learning is much better. If you have to teach skills, say you want to teach communication, and you have to check whether they have learnt or not, it has to be in a smaller group. We obviously cannot teach communication or an injection technique, for example. If you have to teach how to give an injection, even on a mannequin, the group has to be smaller. We may only be able to demonstrate a video or demonstrate it in a larger group. but actual learning will have to be in a smaller group only. There is a chance to monitor one's own learning. The students themselves, when they compare themselves to the others, when the others are speaking, they can monitor their own learning. If they have some misconceptions, that can be cleared. They get motivated. Peer learning is better when it's a smaller group. They get motivated by their friends. And definitely one of the most important points that most of you have put up is individual attention is possible. There are some students who get left out. So you can encourage them. You can ask them to speak, make them interact, make them participate, which is difficult in a larger group. Yes. So how exactly do we go about? There are various methods. We can divide them into the generic methods and the facilitatory methods. When we say generic methods, I'm sure you all are all familiar with all these methods. We have somewhere or the other heard of tutorials, seminars. We have all presented ourselves as postgraduates, group discussions, PBL, problem-based learning, case-based learning, demonstrate, observe, assist, and perform, DOAP, as has been envisioned by or suggested by NMC as well. So many of our competencies, that suggested method of teaching is DOAP, panel discussions, journal clubs. Because let us just quickly touch upon a few of these, not all, but in the interest of time, maybe at least a few of these. So what exactly is a tutorial and how we should be doing it? A tutorial, if you look at the picture, it's for a reason that I have put it in that manner. A tutorial is usually a post-lecture review session. Say you have had a lecture on hypertension, for example, and it is a 1 hour lecture. So obviously you cannot finish everything about hypertension in a 1 hour lecture or even in a 2 hour lecture. So you, following the lecture, you can have, say, the SLO of combination antihypertensives, when to combine, which are the drugs which can be combined, which are the drugs which should not be combined, or specific scenarios where there is hypertension with diabetes, hypertension with asthma, hypertension in a patient of renal failure, hypertension in a patient of heart disease, or hypertension in a patient of angina, hypertension in a patient of heart failure. So all these could be dealt with in a separate small group teaching class like a tutorial. So basically this tutorial would be after the class, where the initial introduction to the drugs has already been done. And this session clarifies the understanding. If there are any doubts, it addresses doubts when the student starts speaking. Any misconceptions which may be there may be clarified. And you have a seating arrangement in such a way, if you see, the teacher is somewhere there, so that there is the teacher is somewhere equidistant to all the students. All the S1, S2, S3, S4 are all the students. They sit in a U-shaped or any seating format, but they are all able to look at each other, and they're looking at the teacher as well. And I've put them in different colors to show that always remember, especially in a small group, that each student has a different perspective to learning. Each student has a different interest level. Each student has a different learning style. Each student has a different mood that day. So we may have to, we need not cater to, but we at least need to understand that every student may not perform in the same way as expected. Always have 1 or 2 SLOs very clearly to be dealt with in that tutorial. Let us stick to that. If it has been assigned to somebody who has not taken the lecture class, then with the person who has taken the lecture class, it has to be streamlined. Which are the SLOs which will be dealt with in the lecture, and which are the SLOs which will be dealt with in the small group. It could be anything from a clinical problem solving activity, or it could be drug interactions of any class. We may have drug interactions following say NSAIDs or diuretics, and the drug interactions part is taken at the end in the small group teaching exercise. The use of drugs in special situations. If not anything else, just pick up some essay questions from old question papers. Following the class, let us have a small group tutorial on the essay questions, because the topic has already been introduced to them. Let them come out with, obviously, they will not come as prepared as they would for an exam, but they have to know at least some things. Let them come up with some answers. You give your inputs as to how to write correctly, what to write, how not to write. So, or if not any other problem solving exercise, at least bring up essay questions or 5-mark questions from old question papers and have it in that way. That makes the students a lot more interested in the topic. Seminars, we have all done this for PGs. We are even doing it for undergraduates in a smaller group. Of course, we can do it in a larger group. The advantage of a seminar in a smaller group is that there is a chance of involving everybody. It's not like the seminar is assigned to one person, that person presents and the matter ends. We may divide the topic into subtopics. This also could be either post-lecture, or it could be a fresh topic, or it could be second half of that lecture. Say we have done, suppose the class is on NSAIDs, we have done general features and aspirin has covered, and individual drugs may be done as a seminar. Announce the subtopics in advance and do not tell them very clearly that it will be who presents will be decided on the day of the seminar. So everybody has to come prepared to present, not PPT, only Blackboard. These are some of the innovations that we can try so that students study and come. All of them should study and come, not one or two who are volunteering. Everybody comes prepared. When they present, give them the feedback, tell them how to improve. There may be some 10% of the students are never prepared, but that's fine. There are students who come there when the lot is picked, they come to know, oh, I have to present, ma'am, I need 5 minutes, I want to go through. Allow them that time. It's not about the presentation. Remember, it's about the learning. Just because they have to present in the next 10 minutes, if they quickly go through and if they've learned even for that 10 minutes, in order to present, the very fact that they're presenting makes them learn that well. Group discussion. A group discussion is a lot more easier to do where, of course, remember always, even in a group discussion, the SLO is very important. 1, 2, 3 SLOs, which may be dealt with in that session. So that we do not move away or become vague. It has to be focused to that SLO only. The difference between a group discussion and a tutorial is that a group discussion could be any fresh topic as well. Initiate discussion. To improve the discussion, we can have questions, etc. Even for a group discussion, we could have essay type questions, we could have problem solving exercises, we could have drug interactions, which was discussed in small groups. Then we have PBL, or problem based learning. This is a much more planned exercise where the problem is planned. Here, the students are not exposed to that at all, to the topic at all. It is some topic which is totally new to them. They, in fact, are not even told what the topic is. So the problem has a title which is very vague. It will not be, if the problem is for anemia, we do not write anemia as the heading. It will be something which does not tell them that this is anemia, because they have to find out what it is. And the students come up with a list of their own learning objectives. So reading the problem, they have to decide what are the learning objectives that they need to know so that they will be able to solve this problem. So at the end of that brainstorming exercise, it's called a brainstorming exercise because the students have absolutely no idea about the problem. They are just brainstorming, just putting in some ideas. They may be right, they may be wrong. They're just storming some ideas. They list out their learning objectives and they prioritize them. They decide which learning objective they should do first, which should be done next. So they have a list of learning objectives. And in the next session, which is usually a week later or even more sometimes, the students come prepared. Of course, during that time, the students have to be told from where to look for answers. The students come prepared and present those learning objectives. They themselves present. So in the brainstorming session, the first session, the teacher just observes and makes sure that there is no deviation from the topic. The teacher does not talk at all, except to make sure that there is no deviation from the topic. In the presentation, the the teacher listens, the teacher can give feedback and finally summarizes and fills in the gaps if there is something which is not covered, something that the students have missed. So that is how a PBL is done. It will have to be decided well in advance before the entire course starts as to which are the topics which will be dealt with as PBL, and making the problem is the most difficult part in such a way that all the learning objectives that we want them to learn should come out when they brainstorm. The problem should be devised in such a way. So next is case-based learning. Now, case-based learning also there is a myth that when we teach them some cases, it becomes case-based learning. It is not exactly that. Of course, we do give case scenarios, and the purpose of the difference between a PBL and a CBL is that a CBL is a very clear case which has been either picked up from your own experience or from the hospital or even from a textbook. But it's a very clear case and the students know what it is about. We have told them this is a case of diabetes or whatever it may be. So it's whereas PBL, they don't even know what they have to learn. They are the ones who come up with the learning objectives. Whereas in a CBL, it is a case scenario. The purpose is to whatever basics we are teaching, the basic pharmacology that we are teaching has to get converted to, or they have to connect it to practice. They have to know how this is going to be used. How is the patient going to present? What to do in case there is a certain different scenario, or what to do if there are adverse effects. So these are the scenarios that they need to know practically. So this CBL would be a link between that. Usually, again, this would be post-lecture, but sometimes we can do something which is totally based on cases without a lecture preceding it. But remember, this is not about just displaying one case as a lid opener. That is not CBL. In your lecture class, if you begin with a case and then you take your lecture, that is not CBL. CBL is when you have only this case in order to explain or bring out your specific learning objective. Whatever you want to teach has to be taught only through that case. There is no other information giving involved there. That is a CBL. The entire session is based on that one or two cases. So you would have, say, for example, if you have a CBL on diabetes and you would have a case of a person being diagnosed. How does the patient present initially? A little scenario about that, and the fasting blood sugar was done. It was so much. So based on that, the first few set of questions will come. It will say, so what is your diagnosis? So let the students discuss, let them come up with a diagnosis. After the diagnosis, then the next question is, now how will you, okay, diagnosis correct, how do you treat? So the case unravels slowly, step by step. Let them tell, based on what will they decide how to treat? What are the factors which will make them choose the drug? Once they have chosen the drug for a newly diagnosed type 2 diabetic patient, what is the dose? How to treat? How long has to this go on? How to monitor the patient? These are the next set of questions. Then the case further moves into, after 5 years, the patient is now on a stabilized dose of metformin. Now he develops hypertension. Now what? Or now the patient's blood sugar is again not being controlled. So what would you add? This is how the whole case develops. And over the next 45 to 50 minutes, you have to teach the entire topic in that way. Next, the one is demonstrate, observe, assist, and perform. This is ideal for your injection techniques, communication exercises, interaction with medical representative. So the idea is to demonstrate, the students have to observe, we assist in their learning, and finally they perform, which may or may not get assessed. So how we follow it is that we first mention the steps to them as a teacher. If there are very clear steps, even if there are no clear steps, make some steps so that some sequence is there to that activity. Even to a communication exercise, make the steps, mention those steps to the students first and foremost. Next, one student reads out the step and the teacher performs, demonstrates. So if it's an intramuscular injection, you first read out the steps. So this is how we go about an injection. Make the students read the step. As the student reads the steps one by one, you perform the injection technique as the rest of the students watch. Next, the students demonstrates and the teachers and the others observe. And this can go on depending on how many students are there or how much time is there. After one student, the next student may perform, the third may perform. And after every student, always give a feedback, or at least in the end, the feedback session to correct any mistakes has to be there. It is a must during the teaching session. It is very easy and very fruitful to give a feedback when the students are small in number. Giving feedback to one student, everybody learns. All the students learn from one of the students' mistakes. Apart from, I have not covered all, but it's easy to find out which are the other generic methods which could be used for small group. In the because of shortage of time, I've covered only few of the techniques which are relevant for pharmacology and can be very easily done, even with fewer numbers of faculty. Facilitating methods. So facilitating methods are methods which help us, regardless of which method you have used, whether it's a tutorial or a CBL or a PBL, whichever method has been used, how to improve interaction, how to improve learning. Basically, the idea is to make sure that in that 1 hour, the student has learned that SLO. So how to improve it? One is seating arrangement. We can have a seating arrangement in such a way that the student feels less threatened. The student feels easy to interact. So we could have, as I said, a U-shaped seating arrangement with the teacher sitting on the top. If there is a desk, sometimes you don't need the desk, just remove the desk. Removing the desk in front of the teacher also reduces that difference between the teacher and the students. Questioning. Questioning is so important. There are different ways of questioning. We could ask probing questions, questions which make the student think. Just open-ended questions or closed-ended questions. There are some students who just don't participate. They are very diffident. They don't want to participate. So for them, we could start with some closed-ended questions. Let them just say yes or no initially. Then slowly that ice breaking happens and then they may participate. So questioning in a very non-threatening fashion, just in order to make them think critically. Give them the time to think. Most of the students don't come prepared. So let them think on their own at least. With little information that has been given, let them think further. Get them, bring the books. Ask them to bring books because sometimes they are not prepared. Most of these sessions require that they have to have some preparation. At least they should have listened to the previous class, which may not occur. So ask them to bring the book. Let them open the book, read there itself. As soon as you've asked a question and they think they have to answer, if they are fine, if they open their book and find out the answer, that should be allowed. Allow them to open the book. Nowadays, most of them are bringing their soft copy in the phone. Allow that. Let them find out the answer. Buzz groups. Madam has already talked about think, pair, and share and buzz groups. Fishbowl. Now, what is a fishbowl? This helps. This is a group of students. The blue circles are the group of students who are doing the activity, and the light orange is the students who are observing. So this is a fishbowl technique where, say if it's an injection technique, for example, or even a communication for that example, there are a small group of students who are doing it. The rest of the students are observing. After this, what happens? The rest of the students get an opportunity to tell what went well, what went wrong, how could it have been improved. So this helps all the students to learn from what the central students were doing. This is a fishbowl technique. This is just the seating arrangement which makes it fishbowl, and the activity which finishes after the activity is over. The feedback or the discussion is what helps everybody learn. Then we have snowballing. Snowballing is where you have, say, 8 students here. So you've divided into 4 groups. two each are given a small discussion to think about. They are thinking, they are pairing, they are coming up with answers, and then you make them combine. So from 2, they've become 4. Whatever the 2 have discussed, let them all discuss together, and they can then finally, more than that, snowball actually means after this 4, they can become 8. But that would become a little boring in pharmacology sometimes, but that is the idea. Then we have jigsaw group. Madam did discuss jigsaw group briefly. I have a small video. So let us see if we can understand it further, because this works very well in small group teaching in pharmacology.
So avoid having some group of 4, some of 5, and some of 6. Later in this video, I'll show you what to do if you can't divide students into perfectly even teams. For this example, we'll assume you're working with a class of exactly 30 students who can be divided evenly into groups of 6. We'll call these jigsaw groups. Step 2, divide your content into 4 to 6 chunks. It's important to divide the content into the same number of chunks as the number of students in each group. So if you have 6 students per group, break your content into 6 chunks. If you're only going to have 5 students in each group, then you'll have 5 chunks. Suppose you're a history teacher and you're doing an overview of different types of government. You could divide your content into these chunks: democracy, dictatorship, monarchy, republic, totalitarianism, and theocracy. By the way, these index cards just represent chunks of content. You don't need to use actual index cards to do jigsaw. A chunk of content can be a section of a book chapter, a handout containing information, or an online resource. Step 3, assign one chunk of content to each person in the jigsaw group. Each group has one person responsible for one chunk of the content. That person will be expected to teach that chunk to the rest of the group. At this point, students don't really interact with other members of the group. They just read and study their own chunk of content independently. Then their independent study is fortified by the next step. Step 4, have students meet in expert groups. After each student has studied his or her chunk independently, they gather with all the other students who have been assigned to the same chunk. These are called expert groups. Within each expert group, students compare their ideas and work together to prepare some kind of presentation to give to their jigsaw group. During this time, gaps in individual students' knowledge can be filled, misconceptions can be cleared up, and important concepts can be reinforced. Step 5, students return to jigsaw groups. Now that students have studied their chunks in their expert groups, they return to their original jigsaw groups, where each student takes a turn presenting their chunk of information. Meanwhile, the other students listen carefully, take notes, and ask lots of questions. Once the first expert has gone, the others take their turns. As each expert teaches their chunk of content, the others in the group are learning it. Step 6, assess all students on all the content. The assessment can be a simple quiz to make sure all students got a basic understanding of all the material. Be sure to include all content chunks in this quiz. Jigsaw 2 is a variation on the basic structure of Jigsaw. Developed by Robert Slavin in 1986, Jigsaw 2 makes one significant tweak to the basic Jigsaw. The difference is in how the assessment is treated. In Jigsaw 1, students are assessed individually and receive just one score. In Jigsaw 2, quiz scores are given once to individual students. Then each group's scores are averaged to generate a group score. This builds in competition.
Briefly about the video is there on YouTube. You could just look for it and see the entire video. I just took a small chunk of it. What is the role of a teacher in a small group? The teacher has to play a very clear role. It is not like in a lecture. The teacher's main role is to manage the group, manage the activities, and manage the learning. Make sure that learning is taking place. So the teacher, we always say the teacher acts as a facilitator, but that it's important to remember every minute that you are just the facilitator. Let the students learn on their own. There is no need to give too much of information. It may be necessary to correct them, to give them feedback, but actual information giving, like in a lecture class, is not required in a small group. We could lead the discussion, maybe start the discussion, open the discussion, guide the process, give it some direction, encourage peer learning. If they're discussing, let them, if you give them a question and then he's asking the neighbor, let him find out from the neighbor, or let them open books, find out, it's okay. And finally, it is important to give concluding remarks, summarize, so that they get, sometimes it so happens that the discussion has gone to so many areas that some students just want that final summary to the entire class. So that is what a teacher would do. What does the student do? Very clear roles, even for the students, during the session, before the session also. We could give them roles like these so that they are also more focused to what is going on. Make one person the leader so that they themselves take this. These are classical roles of students in a PBL, but the same roles can be taken up for tutorials, for CBLs, for any small group exercise, even for a DOAP exercise. Make sure that there is somebody, the student only is keeping time. In the end, make one person summarize the whole thing. Let one person record what is going on, etc. When we give such roles, they become active participants to that teaching exercise. How do we plan an SGT session? We have been asked to, all medical colleges have been asked to put up the timetable well in advance, much before the students even come for the course. So it is at that time that we start planning for our SGTs, at the time of timetable preparation itself. So you have that list of competencies which have to be covered, which you have converted into SLOs, the competence for each competency. What are your specific SLOs? You have already decided. For each of those SLOs, even in the curriculum itself, some suggested teaching learning method is already there. You decide over and above that, for each of these SLO, what is the teaching learning method going to be? Is it going to be lecture or is it going to be SGT? So for the same competency, when you have multiple SLOs, you can have some of the SLOs going to lecture, some of the SLOs going to SGT. That division needs to be made at the time of timetable preparation itself. Once you have a few of your SLOs for the SGTs, then based on what the SLO is, it could be very easy to decide whether you want to do a CBL. If sometimes developing a CBL may not be easy for a particular SLO, go for a tutorial. If you cannot even have a lecture for that, you are only going to do SGT, have a group discussion, seminar, DOAP session. If it has to be a skill activity or a communication activity, it has to be DOAP. So prepare it that way. Have a very clear SLO for each of your sessions, at least one. There could be more, but at least one SLO. And usually for an SGT, the number of SLOs will be less. It would be deeper learning. It will be going deeper into the topic. And finally, summarize, give the feedback to the students. The moment we start doing this, the students' participation improves session after session. It is not without challenges. Definitely, small group teaching is full of challenges. One is, the first and foremost, is it requires much more planning, requires much more time. We do not have time. And of course, the faculty numbers should be more. I have been asked, is it really possible? Is it really practical with the number of faculty that the NMC has put up? Is it possible to do small group learning? We have been doing. With 250 students, we have been dividing them. I will just give an example of how we do. We divide them into 3 groups first. So we get 82, 83 students in each group first. So these 3 groups are going to 3 different departments. 80 odd students come to pharmacology, the other 80 odd go to pathology, the third 80 odd go to microbiology. The 80 odd who come to pharmacology are further divided into 4 smaller groups. So during any small group class, we have 21 students, 4 such groups of 21 students. So I need 4 teachers at a time, which is I have 10 as per NMC requirement. I need 10, I have those 10. And 4 of those, so not even 50% are required for each class. Yes, it is still difficult because it is not just teaching that we are doing. We are doing so many other activities. So it is not as easy as is thought, but it is not impossible. So the take-home message is, despite all the challenges, small group teaching as envisioned by NMC is possible, is extremely satisfying. The students will come and tell you how much they learn from the small group teaching exercises, and it enhances deeper learning. These are my acknowledgements from whom I've learned all my medical education. Thank you very much to the organizers for calling me. If there are any questions, we can take them up if there is time.
Thank you, ma'am, for that very informative
Thank you.
session on small group teaching.
Thank
Ma'am, there is one question in the chat. Could you please clarify the problem-based learning with an example?
Yes. So problem-based learning is, first of all, it has to be a smaller group. Secondly, we cannot do PBL in a large group. It has to be as small a group as possible. So 10 to 12 would be an ideal number, but we have been doing it for 20, 21 students. In PBL, it is spread over at least 2 sessions. The first session, the most important thing in that is the problem. So we have to develop a problem, show it to 4 or 5 of our faculty to see if the problem is good. The problem should be such that it should be a big problem. Problem should be such that the entire topic should get covered in the problem. So for example, you want to cover anti-thyroid drugs in PBL. So you have kind of a case, which is not like a case based where it is not in the medical language. It is an ill-defined problem where it's from the patient's perspective as to what happened to the patient, what all symptoms she had. She went to the doctor, she was given a medication. So the problem is such that all the learning objectives that you want the students to learn from anti-thyroid drugs have to get covered in your problem-based learning, your problem. So you just present the problem to the students in the first session and they brainstorm. We just sit in a corner, not even within their, we're just watching. And both these sessions are assessed. In a PBL, both the sessions are assessed because without assessment, the students may not want to participate. And their participation is marked. Those marks go into their summative exam as well. A part of that goes into the exam as well. So their active participation is observed and it is marked. The other role that the teacher plays is that just make sure that they are only discussing the problem and it's not going to anywhere else. They use the blackboard to write down the issues that are there in the problem. First, they list out the issues, then they make a hypothesis as to why these issues are there in the patient. So they make their own hypothesis based on whatever they have learned in the first year or in pathology or whatever. Once the hypothesis is made, they have to, in the next session, a week later, they have to prove or disprove their hypothesis. So in order to prove or disprove their hypothesis, what is it that they need to learn? That they will list out. So that is their learning objectives. So they'll have 4 columns. First is anything unknown they will list out. They'll have issues, they'll have hypothesis, and they'll have learning objectives. Based on their hypothesis, they have to write the learning objectives so that in the next session, they will prove or disprove the hypothesis. So those learning objectives is what they learn and come. This is their learning objective. They have to read and come those learning objectives. And after the 1 week, they will present those learning objectives. So the learning objectives later are divided by the teacher into the number of students which were there. So we make around 20 odd learning objectives or divide whatever learning objectives they have developed into 20 subsections. and all 20 of them next week present one or the other. Again, who presents what is decided by lots. We do that. And so they all present, and in the end, the teacher gives a summary of that. So that is how a PBL works. So there is hardly no information, in fact, given by the teacher. I hope that in a very short way answers that question.
Yes, ma'am. Thank you for the wonderful explanation on problem-based learning. We hope the delegates have really benefited from the session. Now, we shall move on to the next scientific session, that is effective implementation of self-directed learning in pharmacology. As we all know, one of the goals of Indian medical graduates should possess is to be a lifelong learner. In this context, self-directed learning has gained a lot of importance. It's being delivered in many ways in many institutions. So in the coming session, we would like to know how effectively the self-directed learning can be implemented in pharmacology. So it's my privilege to introduce our next speaker. This is Dr. Manikandan, Additional Professor, Pharmacology, CME, Pondicherry. Sir has completed his MBBS from Madurai Medical College and MD from CME. Sir has more than 19 years of teaching experience. He has contributed to a book called A Practical Approach to Postgraduate Dissertation. Sir is also an associate editor of Journal of Pharmacology and Pharmacotherapeutics. Sir has published more than 20 papers in national and international journals. Sir's research areas interest include essential medicine, rational use of medicine, medical education, and bioethics. So I would like to call upon Sir for opening the next session on effective implementation of self-directed learning.
Okay, thank you, ma'am. Am I audible to all of you?
Yes, sir. We are
Yes.
audible.
So I will share my PowerPoint. Thank you very much for providing me this opportunity for being a resource person in this workshop. So my session is about effective implementation of self-directed learning. So in this session, we'll see about the various strategies. Right. So are you able to see my slides?
Yes, sir. We are able to see.
Right. Okay. Right. So let's go ahead. So just to give an overview of this session, we'll see what is SDL, why do we need SDL, and what are the guidelines, what does NMC say about SDL, and what are the strategies we can follow to implement SDL. So this is in short what we'll be seeing in the next 35 to 40 minutes. The objectives of this session, at the end of this session, you should be able to define self-directed learning, identify the steps of self-directed learning, and lastly, able to implement the strategies to enhance self-directed learning. These are the three objectives of this session. What is self-directed learning? Before going into that, a small historical note of self-directed learning. This, even though many people think this is a relatively new topic, but the concept of self-directed learning is very well known and documented well ages or centuries before. If you see the Hindu mythology, Ekalaiva is a embodiment of devotion to Guru. All of you will be knowing the story of Ekalaiva. So you can know that a complex skill, psychomotor skill like archery, can be mastered mainly by self-directed learning. So that much it has its implications, self-directed learning. And please note that this is not a new concept. This is not a concept which is not part of Indian culture or this thing. It is very well part of our culture and it is a well-known concept. So with that, so let us see what is self-directed learning. The definition of self-directed learning you can see is given by Malcolm Knowles. So what is it? It is a process in which an individual takes the initiative with or without the help of others in diagnosing their needs. So what is the need? Formulating learning objectives, identifying the resources, implementing the learning strategies, and evaluating the outcomes. So please note that it comprises everything in together, right from identifying the objectives, then devising the strategies, then actually implementing and learning, and then finally the most important, assessing or evaluating. So it can be with or without the help of the others. By a literal definition is that self-directed learning is usually takes place outside the classroom, right? Right. Having said what is SDL, why do we need SDL? Why is this SDL a part of our curriculum? What is the need? The first and the most important reason why do we need SDL is that our profession warrants lifelong learning. Say, for example, we as practitioners will be using drugs which we never learned in our medical school, because the advancement of science, everything, evidence also keeps changing. So the important characteristics or attributes of a good physician is that he should be a lifelong learner. How can we be a lifelong learner? If we follow self-directed learning. So our profession warrants self-directed learning. That is the primary reason. The second reason is that the learning pace and style differs between different individuals. It's not that everyone learns with the same speed and everyone learns in the same style. Some have pictographic memory, some are good in remembering text, some understand the concept and try to go for that. So different people learn the concept in different ways. So that's why again this needs to be tailored for every individual basis. How do you learn? What is the pace of your learning? So that best suits for SDL. And lastly, change in attitude can also be brought about. Many of you might be thinking that this SDL is all about knowledge domain. It's not so. Actually, attitude can also be learned or be imparted. One of the important is improvement in self-confidence. He learns by himself. He gains a lot of self. Yes, I can able to achieve. I can learn. That self-confidence improves. So the improvement in self-confidence, collaborating and cooperating with other students and learning. So all these things are part of attitude, which can also be shaped with an SDL. So these are the reasons why do we need self-directed learning. Now coming to the main thing, many of you have already asked the question also that what does NMC say about SDL? This is a table taken from the document GMER 2019, the gazetted one in which this table appears. For each subject, they have clearly mentioned how many hours SDL should be there. So if you look into pharmacology, SDL is for 12 hours, right? So how many for lectures, how many for small group discussion, and total how many is very clearly given, right? So the time duration of SDL is very clearly mentioned. But what not is mentioned is what are the exact topics for which SDL should be carried out and what are the strategies which we should employ. These two are not given, but there are guidelines which topic should be selected for SDL, which should not be selected. First, I will tell which should not be selected is that they have clearly defined core competency in the curriculum. If you see our curriculum, core competency is clearly defined. Core competency or the must-to-know topics. These are usually dealt in by either small group teaching or large group teaching or lectures. There are other competencies called as non-core competencies. So these non-core competencies, if you look into the traditional way of dividing, these come into desirable to know and nice to know. So these topics can be assigned as self-directed learning, right? To add on, yeah, this is one more circular many of you might have seen, really a recent one sent on 31st March 2022. The content of this circular is that the SDL hours may be reduced. Actually, this basically was given for the first year students, that the SDL hours may be reduced, mainly because that COVID situation, the number of hours got reduced. Say the NMC itself gave a guideline that we can reduce the SDL hours, right? Now, a small note about the other curriculum. I belong or I work at JIPMER. So what does this JIPMER curriculum say? How have they defined or how have they identified the topics of SDL? We'll have a look at it. Then we'll go ahead with the strategies, right? Now, if you look into the JIPMER curriculum defines SDL as 10% of the teaching hours for theory should be allotted for SDL. That is by our curriculum. And in contrast to NMC curriculum, JIPMER curriculum, SDL topics have been clearly specified. I'll just show you the screenshot of the JIPMER curriculum. It's available in JIPMER website. You can have a look at it. Can you see? This is for the system. You can see what are all the theory classes, how many hours, everything. Practical for that system is also given. And theory SDL, antitussives, mucolytic, expectorants, coagulants. So for each of the system, they have clearly mentioned what topics should be given or should be covered under self-directed learning, right? So having said that, what is SDL? Why do we need SDL? And what do our NMC guidelines say about SDL? And what does the other curriculum say about SDL? Having seen that, now let us go into what are the 4 steps of self-directed learning, how learning occurs, and then if we know that, we can devise the strategies. Now coming to what are the 4 steps. We need to first assess the readiness to learn, and they should, because it is self-directed, so they should be ready to learn, isn't it? That's the first step. Then specific learning objectives needs to be set. Please remember that one of the important role of a teacher or a facilitator in SDL is that it is our imperative that we define what are all the learning objectives of the session. So that needs to be told to the student by the teacher, actually. Then the person or the student or the learner engages in the learning process, and finally evaluating the outcome. So these are the 4 steps of self-directed learning, right? Now, having seen all these things, let us move to what are all the strategies for implementing self-directed learning. The first broad category or strategy is to promote active learning. Now, why is this strategy followed and how can we do? Already the previous speakers, a lot of people talked about, especially in large group teaching, they were talking about interactive lecturing. Dr. Raki was talking about interactive lecturing and other things. We'll see about why we need to promote active learning. Have a look at this picture. On the top is the passive learning. On the left side, let us have a look. 10% of what we read or what they read is how much we remember. So if we just read something, how much do we remember? We just remember 10% only. Many of you as teachers will be very much aware that many students keep telling that we read, but we are not remembering. As such, pharmacology itself is a very volatile subject. And even anything, if you read, you retain only 10%. Now just come down on the same side to active learning. How much will be retained? 70% of what they say and write. So if they actively do something, if they say and if they actively write something, then how much will be retained? 70% will be retained. So from 10, we can move drastically or increase drastically to 70%. So that's why active learning is an important component of self-directed learning. Please remember that. Having said so, what are the basic elements of active learning? Is talking and listening, writing, reading, and reflecting. So these are the elements of active learning, right? So now let us go into each strategy under this active learning. The first strategy is promote taking notes. So whatever topics have been assigned to SDL, please promote your students to read and make their own notes. I'll tell you why this is an important strategy in learning. Not only for SDL, for any type of learning, notes making is an important strategy. As teachers, many of you might be seeing nowadays, the number of students who take notes have come to very little. People just walk in without anything to the class and sit, or they sleep, or the art of taking notes is slowly vanishing. So many students have forgotten the art of taking notes. We need to remember that notes taking is a transferable skill. It's a life skill actually, because whatever you learned is applicable in many situations. Wherever you go, whatever role you do, you be as a administrator, you take as a physician, or you go as a researcher, notes taking is an important skill and an art. Why are we emphasizing on this? Because it reinforces learning. And it's very easy to brush up or reread or to revise our own notes, and it helps or rewarding in exams. Right now, before we go on to this thing, just let's have a small video to show the importance of the 1 minute. One minute, share. Right, I'll send you the link later on. I think I'm not able to share with you or know how to share this video link. Yeah, I think now it's coming. Just have a look at this. So hope all of you had a idea of how to actually take notes. And sorry, 1 minute. So that's the art of taking notes. As rightly told, it is an art, and we need to improve or to nurture this important skill in all our students, right? So let's go to the second strategy. Again, I think Dr. Raki also touched about this strategy, that is concept mapping. So once they read or learn, please ask them to prepare concept map. What is a concept map? It is diagram illustrating the complex connections that exist between the terms and concepts. I'll show you an example. Ask them to draw relationship and their ideas. It's a useful tool for easy learning of complex concepts and for revision too, right? Have a look at this one, right? The whole process of emesis is just put in one small diagram connected with arrows, the different. So we can see here there is a higher center, there is a vestibular nucleus, the periphery with pharynx, GIT, and chemoreceptor trigger zone. And it also gives each this thing. Have a look at it. One more this thing. So this makes the whole anti-emetics into just one concept map. Can you see here the different structures and their link? How do they act through what are the receptors present, and where do each drug's antiemetics act? Very nicely shown, isn't it? So now if you have to treat motion sickness, you can very really say, okay, right, either we have to give antimuscarinic or antihistaminic, because those are the two receptors. So just if you remember this whole concept map, the full antiemetics chapter is being done, right? So that is the importance, that please encourage them to prepare their own concept maps for the topics which they learn. So that's the second strategy which we have to follow, right? The third strategy, again, it's some of you might have already executed this or followed this in your teachings, what we call as Kipling's table. Rudyard Kipling, many of you might be remembering that he told that I keep 6 corners serving men. They teach me all I knew. Their names are what, why, when, how, where, and who. Right now, how is this Kipling's message or concept employed for a learning purpose? What we call as Kipling's table. I'll give you a small example. Ask students to read, and the template of student that will be provided. Have a look at this. This is Kipling's table for antimicrobial prophylaxis of surgery. Why is it needed? To prevent SSI, surgical site infection. Who needs it? All wounds with clean. So when it should be given? At the time of induction of anesthesia. What is given? How much is given? Where is it administered? Right? So you can just see that with just one table, all the concepts are linked and clearly given. So ask them to read and construct Kipling's table for the topic. That is one strategy which we can employ. Right. Coming to the second broad strategy, which can be employed for SB. Yeah. So to encourage reflective learning. So we talked about active learning. How can we employ or encourage
Joining
reflective
order-
learning for SDL?
ಹಾಗೆ ಕೊಡಿ ಹಾಗೆ ಕೊಡಿ ಹಾಗೆ ಕೊಡಿ
Right.
ಹಾಗೆ ಕೊಡಿ
I am here,
Again,
no,
ಬೇಕಾದ್ರೆ
because I
ಹಾಕ್ಕೊಳ್ಳಿ.
hear other people, those who are on, please, you can mute and talk. Right. So, wilt, there is one more method called as wilt. What I learned today. So the person reflects on what he learned. So after students learn the topic by themselves, ask them to take a paper and reflect upon the following. What are all is reflected? 4 things. What did you learn? So here's what I learned. That is written. Here are some questions I still have. And here are some things which I cannot understand, and any other suggestions. So this tells us not only what they learned. If you have a look at this one paper, you can know, okay, what is not clear and what is that which they want your help or your role of teacher to explain that. So this is a good strategy for self-directed learning, so that you can rope in and explain to them whatever they have not learned clearly. Right. Coming to the third broad category, stimulate recollection and reinforcement. So how can we make them recollect? Recollection is a process which enhances memory. Please remember that many of the students keep telling that we read, we are not able to remember. One of the important techniques in easy remembering is recollection. The other one is linking, actually. Those who have learned these memory courses will be certainly knowing about this. So how can we make people recollect what they have learned, and how can we reinforce? Two more ways of looking at SBL, right? Have a look at this 5th strategy. There is something called as incomplete handouts. I don't know how many of you as teachers provide handout to our students. This is not a full handout, but an incomplete handout. I'll show you an example also. So some facts will be given, but some are left empty. Actually, this can be used during a lecture also, that you give incomplete handouts, might be after the lecture or sometimes even during the lecture along with the students, along with the teacher, they can fill it up. I'll show you one small example. Have a look at this. This is one incomplete handouts which we provide for anti-epileptics. Now, this is a simple diagram explaining the activity of an excitatory neuron, glutaminergic neuron. And the different targets have been marked and boxes are left. Now, they have to fill in these boxes. So part of information means we have provided the structure, the details of glutaminergic neuron, but listening to the class or after the class or after they read, they need to fill this up, and they can retain this as their notes or as their handout. So this is what we call as incomplete handouts, plays an important role in improving the recollection of what they have learned. One more strategy which we have employed is for reinforcing or recollecting what they have learned, is what we call as the word jumble puzzles. Have a look at this. Many of you would be aware of these kind of word jumble puzzles, which are being advertised, as not advertised, which are being put up in many newspapers. I think Times has it. I think sometime back Express also had it. I think a lot of papers it comes, right? Some of you might be fond of it. The same principle is applied. Have a look at this. This is one of our SDL classes, miscellaneous cell wall synthesis inhibitors. So these are 4 terms. It can be drug, it can be an indication, it can be an adverse effect, it can be anything. So they think about all the terms and they try to scramble this, unscramble this, and find out the terms for each of it. And finally, they have to arrange the circled letters and fill in the term as suggested by the cartoon. So this can also be employed for some of the topics to improve reinforcement and recollection and improve the memory. Last strategy under that condition is riddles. I just showing you a riddle. Anyone can make a guess. I think all are pharmacologists. Born in 19th century for gout, but later served a different bout. Tiny in structure, tardy in action, hypothyroidism and trevor, my adverse reaction. Any idea? Actually, this is lithium. So these are some of the ways in which we can increase the attentiveness, they can improve the interest of students so that their memory and learning also increases. Right. Now coming to the fourth broad category of implementing, assisting learning or SDL with technology. As we said, the present generation is always with mobile phones and all kind of devices, isn't it? So how this technology can play a role in self-directed learning? There are different blogs available. People can learn from that. There are Facebook pages. One I have shown here is the medical case discussions, where the cases are discussed, treatments are discussed, therapeutics are discussed. So that kind of thing is one. And most important e-resource which people use, YouTube. I have just shown the screenshot of my own YouTube channel. I also have a YouTube channel. You can type my name. A lot of video lectures are there, which you can see and learn. So the younger generation uses these as the main resource. If you go and ask them, nowadays no one has hard copy of a textbooks. I don't know, I can't read without hard copy of textbooks. But most of people don't even buy textbook nowadays. They have all the thing in PDF only, right? So, but only one important thing which we need to remember, especially in using technology or sites like this, we need to ascertain the authenticity of the information, right? So that's where the role of teacher comes. So as you need to instruct your students that, okay, these are the authentic sites where you can go and learn. These are things which are not to be used for learning. That should always be told to these students, especially for topics on self-directed learning. Right. Finally, you might be aware that the role of teacher is constantly changing. Previously, what we were as sage on the stage is now moving to guide on the side. So instead of just delivering the didactically, the whole teaching process is changing slowly, right? And SDL is in line with this changing role, that we need to be just a guide on the side and the whole learning is taken care by the learners, right? So to conclude in a nutshell, what to see, the role of a teacher in self-directed learning is to provide objectives for learning. What are all the topics that needs to be defined? That's our first role actually. Then whatever topics we have defined, we need to give them what are all the objectives. That's our second important role. Third role is to guide them on the resources for learning, which are the things which you can consult which you can read for this SDL topic that needs to be told to them. We can employ strategies for enhancing learning. And the most important step I have still not told, but I think the definition itself had it, the most important step of self-directed learning. Our role is that this needs to be included in all the assessments, right? Please don't think assessment is only for the topic in which we had lectures or large group or small group teaching. SDL topics should also be included in assessment, because what is not assessed, students never learn. So if you don't assess SDL topics, no one for sure will never learn anything from that. So this is in a nutshell about SDL and their guidelines and what we can do to improve or facilitate learning in SDL. So I'll just stop here, say thank you again to the organizers for giving me this opportunity. If there are, I think I have 5 more minutes to go. If there are any questions, we can take that up. I'll just see the chat box. Chat box, nothing is there. But I think 4 or 5 questions they have already sent. Oh, what is here? Thanks, sir. Okay, right. So how many hours? Already it's there in the NMC. I showed you 12 hours. Is there a time limit for SDL process? I already told you the pace of learning is determined by the learner. But yes, there is a time limit, because time limit is the time in which you will be assessing. Before you assess, say for example, central nervous system, before you have a notified test, they have to finish that. So that's actually time limit. Given topics, what are all the topics? I already touched on that, I think. And how to choose topics also, I think I told during the lecture. And or assessment mandatory? Yes, of course it is mandatory. Anything else? Any other doubts, clarifications, please? We can take up any topic or some specific topics are better. As I already told you, topics, you cannot take any topic. What should not be taken, I already told you. The core competencies should not be given as SDL. The non-core competencies can be put, and it is for you to decide the difficultness in which of the topic also. If you think, okay, this can be learned without the help of teachers, you can always put that as self-directed learning, but only non-core competencies. Any other doubts, any clarifications? Wait a minute, there are 4 comments in the chat box. I'll just okay, thanks Dr. Punai for that comment. Dr. Ritu Yadav, Dr. Sanjeev Gupta. Okay, right, thank you. And anything else which needs clarification? Otherwise, I leave the floor back to the organizers. Thank you.
Thank you, sir, for sharing your experience with us. Hope the delegates have really benefited from the session.
Thank you, ma'am.
Now we shall move on to the next scientific session, communication competencies, teaching and assessment in pharmacology. Communication competencies are one of the pearls in CBME curriculum. As a clinician of first contact, a medical graduate should be able to effectively communicate with patients and their family members about all aspects of drug use. We have with us Dr. Ananya Chakraborty to deliver teaching and assessment of communication competencies in pharmacology.
Thank you.
1 minute, 1 minute. Sorry, ma'am, to keep you waiting. Dr. Ananya Chakraborty is Professor and Head of Pharmacology, Vaidehi Institute of Medical Sciences and Research Center. She has done her MBBS and MD in Pharmacology from Regional Institute of Medical Sciences, Imphal. She is a coordinator of Pharmacovigilance Unit, Vaidehi, AMC, member and PT Committee, NABH Internal Auditor. She is a chair of IAEC, WIMS and Research Center. She is a vice chair of Ethics Committee, Manipal Hospital, Bangalore. She is the president of IPS Bangalore chapter. She is a core committee member of South chapter of IACR. She is a member of review team for faculty research projects, RGUHS, past member of UG Board of Studies, RGUHS. She is a reviewer of Indian Journal of Pharmacology and other national and international journals. Her prior affiliations are as research scientist at the University of Washington. She is a medical content manager at Indege, Bangalore. She was a junior resident at OBG department at Lady Harding Medical College, New Delhi. She is a postgraduate and PhD guide. She has close to about 50 publications in national and international index journals. She has organized many CMEs and national and international conferences, delivered invited talks for academia and pharmaceutical industry. She has won the Best Academician Award 2021-22 by the Institute of Medical Science and Research Center. Over to you, ma'am.
Thank you. Thank you so much. Can I share my screen now?
Yes, ma'am. You can share.
Okay, I thank the organizers, for this opportunity today. So the topic given to me is communication competencies, teaching and assessment. Education makes people take their medication. So what do you think? It's a myth or a maxim? Can you please type your response on the chat box? Education makes people take their medication. It's a myth or a maxim? I can't see any responses yet. So, I feel education makes people understand how their medication works. It makes people understand why it is necessary for them to take the prescribed drug. It makes people more conscious to the needs of their bodies, and this results in better adherence. So I will be waiting to get your responses. Yes, so yeah, Dr. Bandari says it's maxim. Some think that it's a myth. So I see that, there are differences in opinion here. Some feel that it's a myth and some feel that it's a maxim. So whatever it is, I feel education results in better medication adherence. So with this, the outline of my topic would be, I will discuss about the communication competencies in pharmacology. I will discuss about how to teach and assess prescription communication, the teaching learning methods, the assessment of skills. The previous colleagues have, very nicely discussed. Yes.
Your voice is not clear. Can you please use headphone if possible? It's echoing.
Okay. Okay, is it okay now? Hello.
And there is still some interruption in the voice. You can continue. We'll see.
Okay, or maybe I can change my position, right? Just give me some time. This is fine now. Is it okay now?
Still echoing now. Ma'am, do you have simultaneously the YouTube link open?
Yeah, I think that's right.
Maybe you can. Yeah.
Yeah, I'm getting out of it. If there are questions, I think you can inform
Yes,
me.
I will tell you.
Okay, okay,
At the
thanks.
end of the session, ma'am, we'll discuss.
Okay, yeah. So, we'll discuss about how to teach and assess prescription communication, and we have wonderful sessions like my previous colleagues have, given all the techniques, and then, how to assess the skills, and then, I want to share our experiences of prescription communication. As you all know, the backbone of communication is that, a sender sends a message and the receiver receives the message and then, provides a feedback. So in the previous sessions also, we kept talking about, taking student feedback. So I think this is a very important aspect of communication. So communication can be verbal, non-verbal. So communication competencies in pharmacology, these are listed in the NMC guide document. So PH 5.1, it mentions that the student should be able to communicate with empathy and ethics on all aspects of drug use. And we can have collaboration with the Department of Medicine for this, that is integration, vertical integration. Then PH 5.2 talks about communication regarding optimal use of drug therapy, also mentions about the use of devices and storage of medicines. 5.3 talks about motivation of patients with chronic diseases to adhere to the prescribed medication. That is, it talks about we have to train our students about guiding patients on medication adherence. And then explain to the patient the relationship between cost and patient compliance. That is, cost plays a very important role in medication adherence. Demonstrate an understanding of the caution in prescribing drugs likely to produce dependence. So it is recommended that we collaborate with the Department of Psychiatry for this competency. Demonstrate ability to educate public and patients on various aspects of drug use, including drug dependence and over-the-counter drugs. 5.7 competency talks about demonstrating an understanding of the legal and ethical aspects of prescribing drug. For this, it is suggested that we integrate with the Department of Forensic Medicine. So with this background, we have the competencies. I think all of us, because CBME is implemented very recently and we have a lot of challenges, and with COVID, our, the duration of the course was shortened, but, but we all tried our best to do the best possible in whatever the situation we were in. So what to communicate? So we have to guide the students on what to communicate. So for this, can we have a standard checklist? So, I was thinking, like, if we can tell the student to use SCODA, that is use of drugs, all aspects on drug use, and then cost of treatment, drug dependence and management, then educate them on OTC drugs, then about legal and ethical aspects of prescribing drugs. So these are, the competencies on a nutshell. There are 1, 2, 3, 4, 5, 6, 7. So 7 stuff that they really need to know in communication competencies. See, I'm not talking about the ATCOM module here. This is about our pharmacology module. So aspects of drug use, drug adherence, cost of treatment, drug dependence and management, then about OTC drugs, about legal and ethical aspects of prescribing drugs, then optimal use of medicines, device and their storage. So, I use the mnemonic, use SCODA, so that at least if they forget also, if they keep in mind about this mnemonic, so they can communicate actively with the patients. The 5's R and 5 C's in communication. So 5R framework. So the NMC guide document has given the document, specifics about what to communicate. So why is the drug needed? Which symptoms will disappear and which symptoms will not? When is the effect expected to start? What happens if the drug is taken incorrectly or if the drug is not taken at all? Which side effects may occur? How to recognize the side effects? How long the side effects will continue? How serious the side effects are? What actions to take? Where to report? How the drug should be taken? How long should the treatment last? What to do with the leftover medication? How to store the drug? When to come back for follow-up? Whether everything is understood by the patient. And finally, the most important aspect is to ask the patient to repeat the most important information. So as I said, communication is a two-way street. So we have to try to understand whether the patient understood the information. So it's very good to ask the student to repeat the information. Here, student I am talking about is a simulated patient, maybe to repeat the information so that the 5R framework for prescription communication is taken care of. 5R means reason, regimen, risks, revisit, and revision. So also the students need to know what to talk in how much detail, and that also depends on the demography of the patient, on the socio-economic strata from which the patient is in. We should not be giving too much information that the patient cannot follow, or whether the patient is naturally curious to take the information. So all those things should be taken into consideration for a shared decision making on prescription. As my previous colleague mentioned, NMC wants us to shift away from the didactic lectures to what is called guide on the side, as Dr. Manikandan rightfully mentioned, guide on the side. To be guide on the side, what we need to do is to train our students on these various aspects of communication. And then the 5C framework, it talks about verbal, non-verbal, written, visual, and the listening skills. And so what are the various communication teaching methods? I think already we have had discussions from the morning regarding lecture, regarding small group discussion, regarding how to conduct STL and how to assess those. So we can have instructional methods, that is lectures, seminars, personalized audio-visual aids, then podcasts, like that is from experts and patient stories. They really stimulate and motivate the students. So our main aim is to motivate them towards self-learning. And the experiential methods, the various methods towards prescription communication that we can use, they are, role plays, prescription talks, videotaping the learners, videotaping perceptors, then simulation of doctor-patient communication, and then finally, performance in real-life settings, wherever feasible. Again, I'm saying performance in real-life setting, wherever it is feasible. So, I want to start with a article that was published by the CME, is organized by, institute from Karnataka. So here I want to acknowledge the work of Dr. Lavanya and team who published this role play as an educational tool in medication communication skills perspective. So this was published in Indian Journal of Pharmacology in the year 2016, much before NMC document about how to conduct the classes, right? So what did they do? So it was a questionnaire based study. It was conducted in second professional MBBS students, and they conducted the session through peer role play sessions, and they prepared structured scripts and structured checklist for feedback. So they used 6 training cases. They designed 6 training cases, keeping in mind the learning objectives and the Calgary Cambridge guide. to the medical interview. So what does the guide mention? It mentions that, it's about doctor-patient communication. That is how to initiate a session, how to gather information about physical examination, about explanation and planning, about closing the talk, right? So this is about, building a relationship, and, the guideline, the Cambridge guide, it provides a structure to doctor-patient communication. So Dr. Lavanya and team use the Calgary Cambridge guide for medical interview for communication process. And then they prepared the training material based on that, training material for students and faculty. So a structured script for students were prepared. It included concise patient and physician briefing sheets. So in the methodology, they used three students. So one student simulated as a physician, one student played the role of patient, and another student played the role of an observer. So we were talking about teams here. They divided the students, and they had a team of 3 for these sessions. One student played as a physician, one student played as the role of patient, and one was an observer. So they were allowed to choose the training cases and their roles. The role plays were held during regular pharmacology practical classes. Students attended a lecture class on the general aspects of communication skill, both verbal and non-verbal, and then along with the technical aspects of medication counseling, that was a problem-oriented learning. So they used the Cambridge guide. They had the standard cases, and then they had a session before the students were prepared for role play. The faculty moderated the discussions and provided the concluding critical constructive feedback addressing the medical and communication related to the issues. So you see, they trained the students, they provided the checklist. So the planning was very important, right? So they had these, 6 cases. What did they find? They found out that, role play is an effective means for communication skills, and it builds up the confidence of the students, and they retain the pharmacology concepts better. So now I move on to, another published paper that talks about prescription talk. So what is prescription talk? So it is prescription talk as an approach to teach patient-physician conversation, right? So what did they do? So it was a 1-week course for the 3rd to 5th year medical students, and they had simulated actors, simulated physician patient actors. So basically, the students were asked to give first an impromptu talk, and then they were given a conversation guide, and then they were asked for the second try. And then both the impromptu talk and the second try, they were video filmed to allow for content analysis. So the learning effects were also assessed by a written test. So this is the 7 days, 1-week module. So they introduced problem-based learning, and then they took a lecture on the videos. It was on antihypertensive drugs. So lecture on antihypertensive drugs, like my previous colleagues mentioned, how to include the students, even if it is a big group, we can divide them inside the class, and we can give, specific learning objectives, and then ask them for, self-studies, and then towards the end, the teacher can give feedback. Also teach communication. I think it's very important now. I see this trend. Even our students, they don't want to read books, but they're very tech savvy. So you just give an information, and they're ready to learn from online sources. So take the right insulin dose at the right time. So I just wanted to show you. So in the previous presentation, presentation, Dr. Manikanthan mentioned, he showed us a pyramid where it was mentioned that, 90% they retain by doing. So if we can have a demonstration of, a personalized or audio-visual aid, and then we can plan for a DOAP session, and then, when they do, they remember better. We can also expose them to podcasts, expert and patient stories. So I have included one from FDA website. So this is a podcast. So this podcast is about, explaining the newly generated adverse reaction or side effect to the drug buprenorphine. So what we can do is we can play such podcasts in the, in the classroom, and then we can ask them to write down the points of, what they have learned, or so sort of a reflective writing they can do. So there are published papers that talk on simulation of doctor-patient communication. So it is published in the year 2021. Very recent article, a simulation-based module in pharmacology education reveals and addresses the students' deficits in learning prescription talks. So if you see, what they found is, so they divided the students into 3 groups. So the black part, they are the students who were involved in simulation. And then these are the people who observed simulation and role play. These are the people who observed the role play, and the white colored ones are the students. They were not introduced to the simulation role play based learning, right? So what did they see is, if you see all the aspects that were scored, the group that personally performed the role play in a simulation setup, they learned the concepts better about communicating adverse drug reactions, instructions for use, the mechanism of action, drug history, then consent, purpose for treatment. So everywhere they scored more than the students who were not exposed to this role play or simulation setup. So either whether they're observing or they're performing. So the level of education was more in both the groups, but it was less in the group who attended, the didactic learning. So when I talk to my colleagues from various institutes about how they assessed communication skills, I think in most of the institutes they opted for OSCE for communication skills. And if you see total grade received in the drug therapy communication objective structure performance evaluation station for attendees, this is 133 students. And this is for 46 students, non-attendees. So attendees of OSPE and non-attendees of OSPE, there was a significant difference between the level of education in both the groups. OSPE for communication skills. So given they were given a short case scenario with information about the patient's identity, a complete prescription including drug name, strength, dose, formulation, route of administration, and then one specific warning for the given medication. They were asked to communicate this prescription with a simulated patient in the presence of a faculty member. Each student was given 3 minutes to complete the exercise. Performance was evaluated in 3 different domains. The first domain looked into patient greeting and the way the student self-introduced to the patient. So first domain and then second domain looked into explaining the patient's illness and the aim for drug therapy. The third domain looked into students' capability to communicate the details to the patient. So the total score and the scores in each individual domain of attendees and non-attendees in the station were compared, and as we see, the attendees scored more compared to the non-attendees, and there was a significant difference in the score. Assessment of behavioral domain. I think the NMC document already gave us this assessment scale that was adopted from Calabazo consensus statement. So whether the student builds the relationship with the patient, whether the student opens the discussion with the patient, whether the student is able to gather information, whether the student understands the patient's perspective, whether he or she shares information, adequate information with the patient, and the information, I think we can prepare a checklist of how, what, when, where. So I think there are almost 25 questions given in the NMC document. So we can grade based on that also, but this is about behavioral domain. So whether the student, we can't be very strict also, because here we are talking about undergraduates and our main aim is that, the student should learn. And then the student manages the flow. So there are these. So in my institute, what we did is we graded, and then, we use this scale. I'm sure most of you would have used this scale. So we use this scale for prescription communication and also for our at-home modules. So the rating between 1 to 3 is poor, 4 to 6 is satisfactory, and 6 to 10 is superior. Yeah, so with this background, I want to share the experiences, our experiences at my institute. So we have 250 undergraduates and in a batch, and this last year CBME batch, we had 224 students. So we divided into 15 groups. And we conducted the sessions during the practical hours. Unlike, Manipal, we have 2 sessions for students each week, 2 sessions, 2 hours. So 224 students are divided into 2 batches, so around 110 to 12 students in each batch. So at any time point, so for 2 hours, we had 112 students. So overall, we divided all the students into 15 groups. So the duration was 4 weeks. So we taught the prescription communication competencies over 4 weeks. We also invited our colleagues from medicine department, forensic department, and we plan to include psychiatrists also. So the first week was only on orientation. We talked to them about how to write a prescription, how to communicate to the prescriptions. So that was plainly on orientation and the division of the groups and assignment of roles. So the students were assigned roles, and then we allocated them the training cases. So the steps followed are preparation and explanation of the roles by the teacher in the first week. Second week, we gave time to the students. We asked them to get their standard textbooks to the classroom, and we gave time for for their own learning. And so students were left to prepare prepared under the supervision of faculties to prepare for the role play sessions. Then third and fourth week, we had role play by students, 20 minutes per group, and then 10 minutes for doubt clearing session. So we gave them time, we gave time to students also, their peers, to ask questions after the role play. And after that, faculties provided feedback. So you see, like, this is a photograph of our first CBME batch performing their role play. So here, they were also interested to have an assistant to the doctor. So she's playing the role of a doctor, and what we observed is, I think because they started going to the clinics, so every doctor, they want to have an intern or a PG. So she's playing the role play of a doctor, and she has her teammate who is playing the role of a nurse or intern or a postgraduate. And then here, one student is playing the role of a patient attendant, and we had another student, who were dictating. So what did we find out? The scores. We found like significant increase in the level of education after. So what we did is, we dictated the prescriptions, and then we gave them writing task on prescription writing class. And they had to communicate the prescription to the patient. That also was a written task. It was not an OSPI, but we asked them to write. So what we found out is, after the role play, there was, significant increase in their communication skills and prescription writing skills. So assessment was done based on written and observation. By observation, we mean the behavioral aspects. And I already mentioned our faculties, I think at 89.6 of us were there in the classroom. So we provided feedback to them on, what was good and then what could be added. So students were given prescription writing exercise, pre and post prescription communication session. The scores before and after the sessions were tabulated and analyzed. So the cases were given like 50-year-old male suffering from diabetes, hypertension, keeping in mind of the NMC guideline that we should have chronic diseases, we should have OTC prescription, we should have drug dependence into consideration. So it was not a problem based, it was a direct question given to them, and this is what we could do because our students were out of campus for COVID, and I think the last 3 to 4 months they were with us, and I thank my over enthusiastic team of colleagues, so we could plan on this. So the prescription writing scores, if you see in all the groups, the writing scores increased significantly after the role play session. So we scored them out of 10. So we had 15 teams. Role play perception of students, after the role play sessions, we designed a feedback, standardized feedback was taken, and then what they mentioned is role play overall feedback. If you see here, like overall feedback they gave was very good, and then role play concept is innovative and worthwhile, and then they are completely satisfied with the role play as a teaching planning tool in prescription communication. Then I appreciate the importance of communicating drug therapy details to avoid medication errors. I have learned thorough effective feedback from peers and faculty. I understand the importance of teamwork. So these are the various things that came out, a team, they really enjoyed the teamwork, they liked the concept, and then, they thought learning was better because of the role play sessions. So this is another thing that we introduced. This is our first Archimedes study. Our student, he was in his second year, and he did a project that looked into the adherence of meter dose inhalers. So he designed posters, and these are, he has gifted it to the Department of Respiratory Medicine. So because NMC guideline mentions about drug adherence, so we thought it would be good to invite him to come and interact with his peers about, medication adherence and about his experience of directly interacting with the patients and, about his findings from his study. So, the students thoroughly enjoyed the session, and what we observed is, as, my previous colleagues also mentioned, guide on the site. They loved the session when their senior addressed them on medication adherence, and we just facilitated the session, and we received a very good feedback about the session. Patient education at hospital lobby. So during the pharmacovigilance week, because I think that was in the month of August. So before that, actually, we have introduced these role play sessions, and students, the group of students who performed very good in the role play, the first 3 teams, we scored their performance, and the first 3 teams were given the chance to perform the role play at the hospital lobby. So you see here, like in the hospital lobby, again, like 4 of them, one she was announcer, and then patient, doctor, patient attendant. So they performed in the hospital lobby. So the main objective was to make them perform. Like it's not like we give a didactic lecture, we teach them. No, we wanted them to learn through performances. Over-the-counter medicines, we invited the students and we asked them to prepare posters on, over-the-counter drugs, and we gave them the topics. We asked them to prepare posters mentioning the risk of over-the-counter medicines too. If I remember correctly, we had given the proton pump inhibitors, and then I think steroids, over-the-counter steroids, and then what else did we give? Over-the-counter steroids, and then steroid, proton pump inhibitors, antibiotics. So like that, we have given topics, and they prepared posters and they presented during the pharmacovigilance week. And again, like this was catered towards the same thing, towards the competency that students need to learn about communicating medication adherence. So this is our team with the students, who actively participated, who spent time during their lunch hours and designed posters, flyers for the pharmacovigilance week. And then we also designed medication cards for the patients, and our students assisted us. In fact, they sat in the lab and they designed the medication cards that we distributed to the patient during the pharmacovigilance week. So another thing, learning from role models. So prescription publication, learning from role models. Right, so I think NMC, that is a very good thing that they introduced the prescription audit now. So you see, in the pandemic module, I introduced the students to the audit of pandemic prescription. So, and then during that period only, we introduced them to the need for medication reconciliation. And I read some articles. There is an article published from Nepal, so it talks about the experiences of medical undergraduates about reflection. So what they mentioned is, I have not seen doctors talking so kindly to patients. I'm talking about role model here. I have not seen doctors talking so kindly to patients. And he just sat on the chair and holding his hands and asked, "How are you? Did you sleep well? Everything. How is your appetite?" He was asking so kindly, as if he was the son of the patient. So, other than, teaching them, like we also need to expose students to these type of scenarios where they observe their role models and they learn from them. So in summary, teach me and I forget, tell me and I forget, teach me and I remember, involve me and I learn. So today, I left my medical institute way back in the year 1998, but I still remember one incident. My surgery professor during one of our classes. He had asked me to prepare a pedagogy on blood supply and innervation of the thyroid gland. And I till today, like, I feel so happy to remember that incident. That I was the first student in my class. We didn't have the facility of all these new aids for teaching and learning. Like, it was the standard blackboard those days. So I stood there and I explained the steps to my peers. And if I can remember even today, after so many years that I left my medical school, I still remember and I feel, tell me I forget, teach me and I remember, involve me and I learn. So this is, my team, because of which the implementation of CBME curriculum has been possible. We adhered almost 90% to whatever was expected of us. Thank you. I thank everyone, the organizers, the participants of today and my institute for for allowing me to be here, sharing our experiences of implementing the CBME curriculum, especially the communication skills and in pharmacology. Thank you. Are there any questions?
Questions in the chat box. Thank you, ma'am, for that elaborate session on communication competencies in pharmacology. It was very informative. There is one question in the chat box. What is podcast?
Yeah, broadcast is, what is broadcast? I want to ask that question. What is broadcast? So podcast is nothing but, you record something and you keep it for a future use. And, I showed you, FDA has a podcast for medication safety. So it is a recorded, I think, voiceover that can be used later.
No questions in the chat box. We can wind up the session. We can break for lunch and be back by participants. Please note, we are breaking for lunch and we can be back by 1:50 p.m.
Thank you,
ma'am.
Good afternoon.
Welcome back. Good afternoon, sir. Welcome back, all the delegates. Now we shall move on to the next session, that is assessment methods in pharmacology. As you all know, teaching pharmacology involves various teaching learning methods, and there is a robust need for the assessment methods also. So assessment method implemented should be equally important as the teaching methods. So we are privileged to have with us Dr. Dinesh Kumar Badiyal to deliver the session on assessment methods in pharmacology.
Good afternoon, everyone.
Good afternoon, sir. To introduce, sir is Professor Pharmacology in CMC Ludhiana. Sir has been serving under various cadre. Sir has been Vice Principal, Professor and Convener, Department of Medical Education, Program Director for FAMER Regional Institution, and NMC Nodal Center for Faculty Development at CMC Ludhiana. Sir has contributed significantly for the designing of new competency-based UG medical curriculum. Sir has been a member for NMC Task Force for implementation of competency-based UG curriculum. Along with all this, Sir has been awarded various fellowships by the foreign universities like Philadelphia, German Academic Exchange Services. Sir has been awarded Professor G. Achari Oration by the Indian Pharmacology Society. He is awarded International Fellowship in Medical Education by FAMER and ML Gupta Award by Association of Physiologists and Pharmacologists of India. Area of interest of Sir include faculty training, assessment, development of simulation, and competency-based curriculum. Sir has been senior editor for Indian Journal of Pharmacology, and he has been faculty in international national pharmacology faculty development programs. Sir has published more than 120 papers, and he has written research modules for Open University UK. Along with this, Sir has authored 2 books and contributed other chapters in others. Sir, the floor is yours. You can share your screen from your end.
Yeah, thank you so much.
Thank you, sir.
See, earlier, right. Can you see the?
So we can see your slides.
Yeah. Thank you so much. I hope our audio is clear.
Yes, sir, audio is clear.
Yeah. Thank you so much to the organizers for providing this opportunity to discuss about assessment methods in pharmacology, especially when we talk of competency-based medical education. I will share some of the experiences as well as the guidelines which are there. So what we assume is that after going this session, you are able to understand the concept of assessment in pharmacology in the competency-based education. What are the salient changes in the assessment, internal assessment, methods of assessment in pharmacology, and what are the challenges in implementation of those. So when we look at competency-based medical education, all of you might have gone through already these things. This is an outcome-based education which uses competency framework to design, deliver, and remember, note here, assess and evaluate the curriculum. So assessment is an important component of that. As I go forward, just try to see here that when we talk of this competency-based education, there are a few components here which you can see. And out of that, when we define a competency, you will see there 2 words, the habitual and consistent use of communication, knowledge, technical skills, clinical reasoning, emotions, values, reflection in daily practice for the benefit of the individual and the community being served. So these 2 highlighted words, habitual and consistent, need to be observed consistently, or in a way, consistently, the student consistently demonstrate the desired behavior, which we are targeting as habitual and the consistent component. Remember that this is very, very important. It means in the CBME, one of the major changes is that how we change the assessment. Remember, most of the places and countries where competency-based education is there, where the assessment was robust and changes were implemented in the appropriate way, the implementation was successful. If you don't change assessment in CBME or it is not implemented appropriately, then what happens? Their chances are their failure of the new curriculum or the CBME curriculum. You might have seen some example in the last 2 years also. So let's go further into that. I want to ask all of you, what is the purpose of assessing students in pharmacology? And I will request organizers if they can put it into the chat function.
Yes, sir, it will be done.
You can type your answer in the chat box. So I see participants, and participants also, if you want to ask, you can maybe raise hand, use that option. Yeah, I can see Preeti has replied to know what they have learned, what we have taught them, but at this time need to evaluate how much and how much and how well. Thank you, Preeti.
Other people are also responding, saying to assess the learning.
Yeah.
To measure the learning. Maybe.
Yeah. To measure the learning. That's another good example. Yeah. Anybody else has a response? So when we ask this question, typically various responses we get. And one is that one purpose is to prove end of course assessment. For example, when we decide pass, fail, progression or selection extra. Another is a variation of that, improve. Ongoing assessment, continuous assessment for improving the quality of learning. These are two major purposes of assessment. Based on that, you will choose the assessment method to assess the students. And when we talk of assessment in CBME, we talk of prove and improve. In that, role of effective feedback is very, very important. So in the feedback, you will see that it helps learner to improve, which is a major emphasis in the competency-based education as compared to a traditional curriculum. This should be an ongoing process. So idea is that you can derive any deviation in the learning as soon as possible so that immediately some feedback is provided. The teachers decide if the students have acquired the desired competencies. And students, on the other hand, they acquire and improve the competencies. So I see a few more responses to measure their simulation level, how they have understood or mastered the topic. Yeah, that's also one of the components we are looking at. What I want to show you, start with that, before going into assessment methods in pharmacology, UG and PG both, first try to understand what is the change in assessment, concept-wise. You might say that I am putting same theory questions. We have the same practical examination. So what is the change? Why we say assessment is different in CBME? So if you see in the CBME, the curriculum is learner oriented and the assessment is moving to integrated, mostly formative. I'm trying to use now a T-bag model to show you, demonstrate you. Try to observe the changes and I am going to ask you your observations. And I expect that your responses will be there. You can type in the chat or just unmute yourself and or raise your hand. So I'm putting something right now here. Can you see 3 glasses? Anybody can respond? Yeah, or the organizers?
No, sir, we are unable to see.
Yes, sir. Yes, sir.
Yeah, let's try to observe this phenomena now. These are 3 students. Okay, traditional curriculum. And usually most of us, when we prepare our teaching learning methods, and we have teaching learning methods, we give them the same type of learning. So same lectures. So these are the tea bags I'm putting, same brand, everything is same. And same duration also. For example, you have 1 hour session for lecture or a practical or clinical class. Okay, so when the time is over, we take it. All the students get the same teaching learning methods. And remember, in the traditional curriculum, suppose the middle one, this class, this person has achieved 35% internal assessment. So this person will appear in the university exam. This person has already achieved more than that, so both will pass. Okay, in 5.5 years till now, you know, even 10 years people are doing MBBS, 20 years. So it is a time bound. The role of assessment was like this, mainly largely formative. Now what is happening here in the traditional versus now if we think this is a competency based? What we will do in that case is 3 students. You find competencies are already defined at the national level. And why we need to see one of the student is not achieved that component. So maybe this students need some more help. First, identify what is needed. Is it a color? See, today you are able to see the glass through the online media. So you can see only the color. I can even taste it or smell it as an internal teacher. So I will try to identify those needs, give more teaching, learning or support. This you need to tell. For example, if in pharmacology, you are telling them how to inject intramuscular, they are not able to do, they are not competent, provide help. Teacher's role will be assess first what the feedback is needed, provide help, and then make them competent to that level. This is certifiable competencies also, which are there in the communication. You will be doing like that. You are observing 5 times. You are putting up how much is needed, and that is needed. Thank you so much. So what did you observe in this one? In the glasses or in the entire process? Anyone? You can type in the chat or you can just unmute yourself. One is preparedness. Yes. Thank you, Sanjeev. Any other component you could observe? You can ask whatever comes to your mind. Student-centered, yes. Basin, that is correct, that this is student-centered because we are now largely giving some of individual support which is needed. So we try to blend this all method, you can see. Yes, very right, Sheetal. All students are different. That's why if the particular students need more help, so you will individualize your support accordingly and do that. So that is assessment. So it is a learner oriented, but in mainly outcome based. The last point you see on the slide. Thank you so much. So we call this as a T-bag model for competency based assessment. And if you see here, it's mainly outcome based. So it is not time based as such. And you know, now in the new curriculum, after 4 attempts, students will be out of MBBS. Okay, similarly, it happens in now the total duration is also fixed, which was not there earlier. So let's go forward. So T-bag model, very famous model by our ex-president APJ Kalam, missile man of India. when he first designed these missiles, okay, there was a lot of apprehensions, but then they were hitting the target. So if you look at this component, the target here is the new curriculum or the final examination you can see, and see how many corrective actions are needed here. Okay, it's not that this is going in this direction, so teacher will intervene. You have done some support, but that is needed continuously. Okay, so that student needs there. Here, your role is as somebody who is trying to identify the needs and provide that feedback or the support which is needed. So achievement of competencies, feedback is provided, remedial measures are given. I am going to share example of a remedial measures. For example, right now the regulator says remedial measures has to be found by each university. Our university has made what happens if the student falls short of in the summative or university examination. So remember, right now this has to be in paper. So in the pharmacology also, if somebody fails, not able to up to the mark, what is to be done? This has to be written in black and white and not based on the individual students, based on who is that, you decide your schedule. So till now, if you see why we are trying to highlight it is the CBME helps the learner to acquire and develop competencies because you will be helping them. Direct observations play a major role. All competencies has to be assessed. Remember, all competencies. So if you see the number of competency in the pharmacology in all the domains which are there, and 4 are certifiable, which are you are definitely going to put into the logbook. Others also need to be assessed, which is possible when you are doing internal assessment maybe. I'm going to share a model of competencies levels now. For example, let's take example of communication skills, or in the pharmacology, intramuscular IV injections, okay, or use of inhalers. Initially, they are unconsciously incompetent. They're not aware of also that. Then after that, you have some session and they are consciously competent. They know they are not competent at that level. Then they start to learn and you provide some help to them. They become consciously competent. And later on, when they achieve a mastery level, they don't have to read the steps or remember the steps. They are unconsciously competent. So that is a mastery level. So what we are trying to achieve, that everyone at least reaches the competent level. Some might achieve excellence level, distinction level, or mastery level. So this was PH 4.1 IM injection. Where also we have a checklist along with that. The time of assessment checklist is used. At some places, global rating scale is also used. So that can also be done. So that is the one method where we say direct observations, which are coming into the, as you know, the role of Viva is gone, the typical theory Viva. So you can replace that with some stations where you can ask probing questions related to that station. So novice person who starts reaches the mastery level, and it is with the help of the facilitator or the teacher who is there. Major changes in the exam, you know, as such, if the COVID was not there, the plan is first and second year in September, which with the buffer period which is given now, it might take 2 to 3 years to reach back that planned period of September, first and second year. So that is something which is coming up right now. Most of the universities are quite delayed because of the COVID. Otherwise, the total duration is same. And this you already know that total marks in the pharmacology, 2 papers A and B, 100 and 100, and the theory is 100. Internal assessment is also given now in a way that you need 50% combined. Remember, this is combined in theory and practical, but not less than 40% in theory or practical. Then they are eligible to appear in the university examination. Otherwise, they are not eligible, but this should be done quite before, not just 2 or 3 days before the exam. Remember, internal assessment marks, which are 100 in pharmacology now, they are not to be added to university exams. And they are shown separately on the retail marks card. University examination, 50% marks you need in theory and practical. And theory means theory papers now only. Nothing, other components are not added as earlier. So Viva will not be added. There's no internal assessment added. So out of 100, they need to score 50 marks. And also in each paper, it should not be less than 40%. So that criteria is also there. Let's go to some assessment methods and opportunities, which in pharmacology we get. One is internal assessment, which tells you how they have learned, the pathway. Then the university examination, which tells you how much they have learned, the final learning, where you judge, have a judgment attached to that. Remember, both test different aspects and they are not replacement for each other. which sometimes we try to replicate, but they are not like that. I'm sharing a theory blueprint of our university with you people. So if you see here, we have divided paper A and B much before the batch came into that. So every college follows that. Even ATCOM is divided. So this blueprinting is very important so that you can decide the methods. After this blueprinting goes to everyone, including the paper setter. And what happens after that? You see now the methods which are used in the theory. We always say use the mixed methods. So you see the MCQs, scenario based. I'm sharing an example of a university paper. Okay, all are scenario based MCQs here, 20 MCQs, followed by, now you see the variety here. Long essay question, short answer questions. Each one starts with, remember that you see the some verbs are there. Enumerate, describe, comment. These are very important. That's how you design your methods, make them authentic, and also have a mix of that. Then reasoning or explain why, short answer or applied aspects. Question number 5 is specially related to integrated topics, what we call as aligned and integrated topics. So if your university colleges, all colleges are following the same topics, in the university also you have these questions coming from the applied aspects. Then short answers, which are there. Practical blueprint in pharmacology. So on the day of practical or other terminal exams which you take, also that blueprinting has been done there. And also they remember the method which are mentioned are not in the NMC as well as our university, OSPI, OSCE, direct observations. Okay. Methods are not limited to BUB, use multiple methods. Again here, like theory you have seen, so multiple methods should be used. So you can divide them into experimental part, practical record, maintenance, communication, okay, all S and A, psychomotor and affective domains, which will be covered here. So your methods need to be chosen accordingly. I am sharing you one blueprint of a MBBS exam, undergraduate exam. You can start with some questions with the whole class related to rational prescribing. As you know already, this has become very, very important. You have ICMR module also available on the ICMR website for the students now. So where you can either give them a condition to write prescription or analyze a prescription and correct it. Then P list of a drug for a given condition, that can be another question on the day of university examination. Remember that most component has to be direct observations or other analytical questions. It can be followed by problem-based drug interactions. You can add that. And then for the part of the competency 4.1 and 2, remember they are related to the mechanism of action of drugs. For your teaching learning, you should use animation videos of the actual clinically useful drugs in the humans. The same can be given. You can download that. You see a lot of free YouTube videos are available, which are free to use. You have to just give the reference of that. ADR form you can do. If you are a center, you can use VGXS and use some sample format there. So that is a good exercise to do that. Then major component is nowadays is recommended as OSPI, Objective Structured Practical Examination. In the clinical subjects, it is known as OSCE, Clinical Examination. In the non-clinical, it is known as Objective Structured Practical Examination. So you can have more stations here, number of stations here. I'm going to show you some examples of the stations. The sampling of the station should be from all the contents from the pharmacology, psychomotor and affective domain. Do not ask something which can be asked in the theory. That should not be put into that. So here you have a paracetamol given, and based on whatever the doses are prescribed here per ml, person has to calculate the volume which has to be given to the child. So need to tell to the mother about that. And analyze the promotional literature which is given there. So you can keep on changing that. Interpret the given drug level. So what is interpretation here? And right now, remember that the preparations are not there in the pharmacology. The student need not prepare, but interpretation is more important. Demonstrate the use of inhaler. Then you will have a checklist here, a one observer. So station number 4, for example, here will be observed station. Station 5, communication, lot of them are there, which are certifiable competencies. Communicate to the patient the use of the given drug. Okay, then provide sample. Then you need to provide sample, and remember checklist should be given. Even for the communication, there are checklists now, which are very easily available. Then the relationship between the cost of treatment, patient compliance, then you need to talk. Again, the observer will have a checklist. So that is a part of the university examinations where you can vary all these methods, mix and methods. So that decreases the bias, minimizes the bias, also increases the sampling. It means you are able to assess many areas in pharmacology in a shorter time. So you have 150 students or like that in a day, and you have a OSPE running around, and 1.5 hours you can actually take out 30 students statewide like that. And students say this is a very good exercise because this is a non-threatening environment. Nobody is sitting on their head for the viva or something like that. Many places, OSPE is the main examination now because sampling is wider. Second component we are coming to is, lot of you ask, is internal assessment. What is internal assessment and what are the opportunities? Formative assessment also people use a word. Formative is all the day-to-day assessments where you are providing feedback to students. Some of that which you convert into marks and use it convert for calculating internal assessment out of 100, that becomes internal assessment. For example, end of your lecture, end of your system, you're giving some MCQs and all. That is very informal sort of things. Practicals you are doing, some feedback you are giving to the students, tutorial discussions. Okay, so forms can be anything, MCQs, short answer questions, or completion test. So you are trying to assess learning and providing gap, and any gaps which are there, you are adding to that, and but not for computing internal assessment. So usually informal opportunities are based on direct observations. You observe their behavior, even ATCOM components, which are part of each subject now. And focus on modifiable actions, reflections, thinking aloud, which everyone is writing nowadays. And we need to somehow train the teachers also to read the reflections, student reflections, which are very, very important now. These are the regulation for internal assessment before the older batches, 2018 and batch. So all these components can be. New batch, if you see the components which are given on assessment module 3 on the NMC website, you know what the theory internal assessment includes, what the practical internal assessment includes. So theory, you will see theory tests, stand-up, seminar, quizzes, interest in subject. Lot of subjective components are there. Practical, if you see OSPE, there are a lot of other methods which can be used. Logbooks now make up to 25%, 20% of internal assessment. So we were discussing with many people that when you do a university examination, on that day you have a mainly maybe you are assessing knowledge. Even you send the student to perform something, but maybe you are not there. You ask them to come back to your room and ask, okay, tell us how you have done this. But again, that is a knowledge. If he's good in the communication, he can maybe score more. Actually, if he's not even good in the skill. So that is a fallacy here. Similarly, practical skills. On the other hand, day-to-day internal assessment, so many components can be assessed. So you see the assessment of learning, which is university exam, assessment for learning, which is internal assessment. But remember, assessment drives learning. So use all of these opportunities to improve learning of the students. So basic principles in internal assessment are 3. Alert the student about the present position. If they are doing well, reinforce, tell them the desired goal again. And if they need some help, provide that help, tell them how to fill those gaps. So these are very, very important. Alert the student, reinforce the desired goal, and help them to achieve those competencies. You also know there's internal assessment as eligibility criteria. 50% internal marks you need, 40% in each. Certifiable competencies. You might have a logbooks now, so there's legal document, remember now. If you do not certify the competencies, tomorrow they can create a problem for you. So certifiable competency should be marked if they are appearing in that, and you have to observe and mark, not on one day, with a gap of few days in between when you observe on different days, so that you provide them feedback and they take time, learn more and do that activity. Attendance you are already aware about, which is needed. And we have designed a lot of internal assessment schedules for various universities and colleges. I'm showing you one of that. Logbook has 10 marks. Other academic activities, which is subjective, is 10 marks. 80 marks is the marks about the other academic activities. Practical also will have other components, including ATCOM. 10% weightage to the given to the logbooks. So we worked on that, and we made some internal assessment modules also. So this is one of that which is quite frequently used. We are using it for 15 years, almost more than that. And we have modified it for the new curriculum now. So you see here, this is all the tests which are conducted, all the marks you put it here. Other component, tutorials, seminars and others. So percentage will be calculated here. This is day to day. And the end of the phase 1, phase 2, your phase, each teacher, this stage teacher, marks the students out of 10 for interest in subject, active participation, scientific and other component. You can expand this list. Average of this is this is out of 10. So logbook has 10% marks. So that is also there. And similarly in the practical, ATCOM components are coming into that: attitude, ethical habit, communications. So ultimately you calculate it here for theory as well as practical components. So that is internal assessment. And we have a bound register of 100 students in one form. So one register for one class. One page gives you everything about a student, that how the student has been going up and down in the year. There has been no alignment of UG and PG. You might have seen on the website, NMC website, competency-based curricula in MD Pharmacology. That also advises now to take a formative assessment. They have also given some guidelines. It is getting updated also. Maybe in a month or so, you will get a revised version with more emphasis on the formative and formative assessment and how to use that in the MD Pharmacology. I'm showing you one university's final university exam pattern. When they do it in that, they have a long experiment, which can be a protocol designing. OSPI in the PGs, it's very successful, but the time is more. Maybe they are performing something and also the time has to be accordingly increased. Short experiment, you want to show you some human models, or you have animal instrumentation, you want to show that can be part of that. Teaching assessment, remember this is known as teaching assessment, not micro teaching, which is a misnomer here. Micro teaching is always in a non-threatening environment. Exam is a highly threatening environment. Thesis presentation, which you do number of places. Then you have a grand viva as per your university, or you can revise that also. So remember that what is happening major component is we are shifting to this one, formative assessment, assessment for learning in the competency based. So this is for improvement and growth, feedback during learning process. And this is a low stakes marks, number of formative assessments happening versus single university exam, which is high stakes exams. So this is the one component which is needed, and you can actually look into that how we define further on that, build more into that. The major issue is when we talk of using formative assessment frequently, lot of homework is there for the teachers or the assessors. They need to plan assessment. They need to plan it in alignment with the objectives or the competencies, which is in the question. So based on that, they will first plan what methods they will use, the time they know it, how many people are needed on a particular day. You might be doing that already. We all arranging all the logistics for the assessment. And if that goes well, maybe you can say that the process has been an authentic assessment. How it is implemented, sometimes you see various results with the assessment. That will also indicate you which part is lacking. Is it the teaching learning method, or it is the way they were assessed? And you already know we had many issues in the last 2 years with assessment, especially university examinations of the new batches. And now when you see the second year, those have settled a bit. And some of the students I've interacted in various colleges, they say now, sir, we know how to tackle the new type of questions, scenario-based MCQ, scenario-based SAQ, long essay questions. So they are moving away from that 10-year culture to in-depth study, because scenario-based questions usually motivate them to study more in detail. So that is one impact of the assessment which comes when you use any assessment method. You might have heard some characteristics of assessment like validity, reliability, acceptability, but the impact is more important. How it is impacting the learning. And remember, assessment drives learning. You change the assessment, students change their way of learning. So actually it is in your hand how to manipulate that learning. You want to improve learning, change the assessment in that direction only. So you will get those components. So I'm just summing up here. Principles of assessment in CBME in pharmacology, assessment for learning, as well as also now start thinking about assessment of learning. Multiple opportunities are there with all of us as teachers, internal exams, number of you are paper setters, number you are assessor for the universities, number of you are making guidelines for the universities. Use multiple assessors to minimize the bias. Try to bring in the feedback culture in assessment, which is initially difficult, maybe because of the workload you have or the people you have. Qualitative is coming back, words versus mark. A lot of you say the objective is more important. Subjective is equally, or it has more value in the medical education. All competencies need to be done. It means you need to plan continuous assessment that throughout year also you are testing all those competencies. Assessments with the low stakes also need to be taken into care, because these multiple assessments will give you a lot of idea about where a student stands, and it also reduces the examination anxiety. So let me ask organizer what type of format we want to go to ask the questions. We have some time for questions. We can go for some questions. You can type in the chat or you can ask.
Who would like to ask questions? Sir,
Can you be louder?
there is no questions in the chat box.
Yeah, please go ahead.
No question. If anyone has any questions,
You can type in also or ask by unmuting. Yeah, if you even have a questions later on, you can send me through the organizers. So I thank you everyone, all of you for participating, and also the organizers.
thank you, sir, for your elaborative and informative session on assessment methods in current UG and PG curriculum. We have come to the last session of the day on electives in pharmacology. Electives are mainly introduced for IMG to provide learning opportunities in diverse settings and to provide opportunity to do research and community projects that will stimulate self-directed experiential learning and lateral thinking. We need to design or draft a set of electives from which students can choose. In the coming session, we have 3 speakers who are going to deliver on planning and implementation of probable electives that can be designed in pharmacology. First, I would like to introduce Dr. Naina, who will be sharing pharmacovigilance as an elective. Sorry, Dr. Naina will be sharing clinical pharmacology as an elective. Before that, a brief introduction on ma'am. Dr. Naina Hasselkar is Professor and Head of Pharmacology, JNMC Belgavi. She is a co-convener, NMC Nodal Center for Faculty Development at Belgavi. She is Vice Chairperson, JNMC Institution Ethics Committee. She is a Basic Medical Scientist in Ethics Committee ICMR Belgavi and Ethics Committee of KLE University. She is Deputy Director, KLE Research Foundation. She is Member Secretary of Institutional Animal Ethics Committee. She is member in Department of Medical Education, JNMC Belgavi. She is Assistant Director, KLE University Health Science Journal. She is a peer reviewer of Journal of Ayurveda and Integrative Medicine. She is a member of APPI IPS Belgavi branch. She has received the Best Teacher Award, KLE University 2017. She has conducted research in medical education by implementing innovative teaching learning strategies for medical undergraduates. She has been involved as resource person in various workshops like medical education technology, research methodology, biomedical communication, scientific publication, and in the field of pharmacology. She has guided various postgraduate research studies. She has a number of publications in pharmacology and medical education to her credit. Over to you, ma'am. You can share your screen. Ma'am, you're muted.
Uh,
Yes, ma'am. Now you're audible.
okay. Am I audible?
Yes, ma'am.
Okay. Thank you, ma'am, for a nice introduction. Can I start with the session?
Yes, ma'am. You can start.
Okay. Thank you. Very good afternoon to one and all present. I bring greetings from the Kelly Academy of Higher Education and Research, Kahir, Belgavi. Okay, at the outset, I would like to thank the Department of Pharmacology, Kshema Nitte University, for giving me an opportunity to share our experience with planning of electives on clinical pharmacology module. So these are the objectives of the sessions. At the end of the session, all of us try to understand the concepts of electives for medical undergraduates and understand the implementation plan for electives on clinical pharmacology. Since I'm beginning this session on electives, the plan of presentation would be initially I'll be covering very much in brief about the elective concepts of electives that have been shared by Medical Council of India. Followed by that, I will be talking on the implementation plan for electives on clinical pharmacology. So let's look at what these electives are. Now, there are various definitions and understandings about electives, which have been developed by various associations of medical educations across the world and also by the universities globally. But what we are interested in, what we will be looking into is the one that has been given to us by the Medical Council of India, which says that elective is a learning experience which is created in the curriculum to provide an opportunity for the learner to explore, discover, and experience areas or streams of interest which they are not routinely exposed to. So this is what is being given to us, and all of us are very much aware of this definition of electives. They have implemented objectives, or they have integrated these electives into the CBME with the objectives to provide the medical undergraduates with opportunities for diverse learning experiences, as well as to carry out research or community projects that will stimulate inquiry, self-directed experiential learning, and lateral thinking among the medical undergraduates. So these were the objectives of introducing electives into the medical undergraduate curriculum. NMC has also given us, I'm sure all of us are aware of this template which has been given to us by NMC, and which has helped us really and made it very easy for us to plan the implementation of the electives for our specific specialities. Yes, NMC has also provided with the plans for implementation of CBME. It has given the guidelines saying that every individual medical undergraduate will be attending 2 electives, and they have divided it into 2 blocks, block 1 and block 2, and both of them will be for 4 weeks. These are going to start at the end of 3rd first, followed by which there will be block 2 electives. Now, the block 1 electives will mainly cover the topics pertaining to preclinical, paraclinical specialties, also those involving basic science laboratories or under a researcher in an ongoing research project. Now here, the students will be attending their regular clinics during the electives. While the block 2, which is again for 4 weeks, will mainly concentrate on the clinical departments, including the specialties, super specialties, ICUs, blood banks, and casualty, or supervised learning experiences at a rural or urban community clinic. Now, during block 2 postings, the students will not have their clinical postings also. And in addition, we could also have collaborations with the outstation institutions so that it is more meaningful, but with prior permission from the NMC. Okay, so that is about the electives that have been given, the details of the electives that have been given by the module which has been given to us by the Medical Council of India. About the assessment, I'll be talking a bit later. Now, coming to the one that we are more interested in is the block 1 electives, and we have now very less time left for planning of these electives, which we will be implementing once the students give their third part 1 exams. So let's concentrate on block 1 electives, and especially the electives in pharmacology. Now, we can think of n number of electives in pharmacology. This is just a small list which just came to my mind and I have added here. The pharmacovigilance, I'm sure, I think each and every institution would be planning one elective on pharmacovigilance. We could also think of clinical pharmacology, pharmacoepidemiology, economics, genomics and precision medicine. In addition to that, we could have on principles of research in pharmacology by including short projects for the students. We could even think of toxicology. And I was having a word with a colleague of mine who also said that in future, we could also think of artificial intelligence, electives in artificial intelligence. But yes, when we think of all these topics, one thing that we need to understand is the feasibility of these electives. So let's concentrate now on clinical pharmacology elective, which I will be talking on. Okay, so as all of us understand, clinical pharmacology is a scientific discipline that involves all aspects of relationship between drugs and humans. So in a broader sense, it includes development of new drugs, application of drugs as therapeutic agents, beneficial and adverse effects of drugs in individual and society, including deliberate misuse of drugs, and toxicology. So we definitely we understand, that is why a number of courses have come up and specialties have come up in clinical pharmacology itself. Like we have clinical pharmacology related to trials, pharmacoepidemiology, and all these which have come up as a part of clinical pharmacology. Now, let us understand what are the roles of a clinical pharmacologist. So these roles are very important. The first one being his contribution as a researcher in research. He can definitely play a very important role in research pertaining to integrating preclinical research into clinical trials, doing clinical drug evaluations, and being an important part of clinical trials right from phase 1 to phase 3. Research related to therapeutic drug monitoring, pharmacovigilance, epidemiology, economics, drug utilization studies, and so on and so forth. This is again a small list of the research that a pharmacologist can be involved in. In addition to that, definitely he has other roles to play as in teaching, that is academics, as well as important roles in various government establishments, especially in purpose of selection of medicines for public procurement, developing national treatment guidelines, as well as national essential medicines. Now, why I was talking of these roles of clinical pharmacologist is that so that we can actually make it clear to the students when they come to us as to what is the need for an elective in this clinical pharmacology, because they have to understand what is the future, what future do they have if they are interested in clinical pharmacology. So we have to, so this elective in clinical pharmacology will provide the medical undergraduates not only the knowledge and skills for rational therapeutics, but it should also provide them insights into career opportunities for clinical pharmacologists. So we need to understand the students understand what is the requirement of elective in clinical pharmacology and what career perspectives they have as clinical pharmacologists if they are interested in this. So with all that in mind, the Department of Pharmacology took an initiative to develop this elective on clinical pharmacology with the objectives that at the end of 4 weeks training, an undergraduate will understand the rational principles of drug dosing and their practical applications, including TDM, ADR, drug interactions, and other aspects, estimate dose for special patient populations. He should understand the basic principles of new drug development, including clinical trials, and critically evaluate scientific literature with a focus on efficacy and toxicity of drugs. So these were the objectives of our clinical pharmacology elective module. So coming to the implementation plan, with those objectives in mind, we planned this module, which included that, which said that the number of students, the maximum number of students that we are going to allow in this module could just be 20, so that it helps them to get involved in the elective, which is one of the objective of the elective. They understand it and actively participate in the elective. How do we select the students for this elective? Now, this could be applied to any elective, not only clinical pharmacology, but any elective. So selection can be done on the basis of early birds, that is early registration, and we take them, or it could be based on the merit, or it could be based on the success in an enrollment test that we could conduct in the beginning of the elective. The prerequisite that is required for the elective is definitely the knowledge on core concepts in clinical pharmacology. And our students are definitely aware of all this because this has been a part of their routine curriculum, like pharmacokinetics, dynamics, ADR, and other things. What are the resources that we would need for the implementation of clinical pharmacology? Yes, the time, we have 4 weeks. We would be conducting this from Monday to Saturday during the period 2 to 5 in the afternoon, because morning the students will be going for clinics. It will be conducted by the faculty of pharmacology who will be trained. Most of them are trained through CISP 1 and 2. But again, as an reinforcement, we would have a small training for faculty as well as the tutors in the department. The infrastructure that would be required, an extra infrastructure in addition to lecture gallery that we would require for this clinical pharmacology, is the various visit sites like the Basic Science Research Center, Pharmacovigilance Center, Site Management Office for Clinical Trials, Poison Detection Center, hospital wards. Now, I would like to make a statement here that this module has, we have planned based upon the resources that we have. Now, this can be modified as per the resources that are available in the respective institution. So the timetable, now how did we divide the timetable for this? Okay, we have 4 weeks and this is how we have divided the 4 weeks. Week 1 will mainly concentrate on basics of pharmacology and clinical pharmacokinetics and dynamics. Week 2, rational drug prescribing and prescription analysis, including drug utilization. Week 3, ADR monitoring and toxicology. And week 4, drug development and evaluation. So this is how we have divided various aspects of clinical pharmacology, which we thought should be included as a part of elective. So let's come to each week day wise. So the first week, that is basics of pharmacology, including the clinical pharmacokinetics and pharmacodynamics. So this is how we have planned. Day 1, there will be introduction of the students. We would ask them what was the purpose of selecting clinical pharmacology as an elective when the choice was given, plus what would be their expectations from this elective. We would also be telling them about the objectives, the various teaching learning methodologies that we would be using, and we would also be sharing the material that they would require during the process of this elective. So this will be in the form of interactive discussion. So basically, day 1 is something as an introductory class. In addition to that, we would be even discussing with them the basic definitions of pharmacology, which they would have definitely read earlier. What is clinical pharmacology? What are the various aspects of clinical pharmacology? So on and so forth. We would just discuss the basics in the first session. Day 2 will be an interactive lecture on factors modifying the drug action. We are also thinking of giving certain case winners where the students can think of how various factors can affect the drug action. So they could be we could think of group activities there with the help of case winners. Day 3 is drug dosing, including those in special conditions like children, elderly, and disease conditions like renal disease and hepatic disease. So again, there will be an short interactive lecture like introduction to how the dosing can be done. And then we would be sharing various case minutes with the students in groups, where they'll be working in groups and coming up with the dose calculations for various situations. So this will be a case-based learning. In addition to that, we were also thinking that if possible, if there are cases where we could take the students to the hospital, to the medicine or pediatric wards, where we could directly show them how the dosing was done and discuss there, we would even try that if it is possible. Day 4 will be drugs in pregnancy. This will be in the form of student seminar, and they will be mentored for this seminar in the previous 3 days. Day 5 will be pharmacoeconomics. So here we will be having a short interactive lecture again on what is pharmacogenomics, what are the various tools or techniques, methodologies that are used in the study of genomes, and again followed by case discussions by the groups. In addition to that, we plan a visit to the Basic Science Research Center of the university, which is actually doing pharmacogenomic studies, and they're doing a lot of genome studies, and so students will be made well versed with the techniques like PCR and others. On day 6, we have a slot for pharmacoeconomics, again where the basics of economics will be dealt with, and again this will be followed by sharing the case minutes with the groups. They will be working in the groups, and then followed by that there will be group discussion in the presence of faculty. So this is day 1, week 1, which is related to basics of pharmacology and clinical kinetics and dynamics. And what do we do in week 2? Week 2 is concentrating on rational drug prescribing and prescription analysis, including drug utilization. So this is how we have divided. Again, day 1 will be an introductory class, an interactive lecture, which will cover as to what is prescription, what are the parts of prescription, prescription writing, what is rational, what is irrational, what are rational FDCs, and all those concepts of prescription writing, as well as the students will be asked to write prescription for various given cases in groups. So we'll be again using case minutes here. Day 2 will be an interactive lecture followed by group activity on prescription analysis, where we'll be talking to them about basic concepts of prescription analysis and the methods that we follow in prescription analysis. This will be followed by giving them exercises for prescription analysis. The already written prescriptions will be given to groups on which they will be working, and they will be analyzing the prescriptions, and then they will be this will be followed by group discussion, presentation and discussions. Now, followed by this activity on group prescription analysis, we divide the groups into 3 or 4 based upon the numbers that we have. One mentor will be allotted to them, and following on day 3, 4 and 5, the students will be posted to the hospital, either to medicine or pediatric wards, and each group will be given a specific condition or a situation like doing the prescription analysis in elderly or in pediatrics or patients with cardiovascular diseases or only fixed dose combinations or for antimicrobial agents, something. So all this, a number of lists can be made where the students can do prescription analysis. So day 3, 4, 5, they will be doing this prescription analysis under the guidance of the mentor. And on day 6, they will be presenting the audit of the prescription analysis in the form of group presentations followed by discussion. Week 3 is ADR monitoring and toxicology. So here day 1 again is an introductory interactive lecture class, which will deal with the basics of ADR, like what are the various definitions related to ADR, casualty assessment, ADR reporting, with special mention on pharmacovigilance program of India, metrovigilance and hemovigilance. Followed by this, on day 2, the students will be given hands-on training on ADR reporting. This again we are doing as a part of undergraduate curriculum, but this will be a revision for them. This is something like a revamp. So we'll be giving them cases, and this will be a group activity where the students write the ADR reports in the format. Day 3. Day 3, we will be planning a visit to Pharmacovigilance Center of the university, where they will get to know or review about the activities at the Pharmacovigilance Center, including the data entry in the Vigiflow software. Day 4 is the discussion on basic concepts and methods that are used in TDM. Again, we have an interactive lecture with group activities with the help of case minutes. Day 5 is toxicology. This we will be taking it up as a student seminar, where the students will be talking of various aspects of toxicology, poisons and their treatment. And day 6 will be a site visit to the poison detection center of the hospital, where they will review the activities that are conducted at the PDC. Week 4 is drug development and evaluation. So this is how we have planned. So this is where we, the objective of this week 4 of drug development and evaluation is we even train the students in the basics of research methodology. So day 1, we thought we would give them introduction to research methodology, basic concepts, mainly related to defining a research question and review of literature, including critical appraisal. So following by the interactive lecture, we would be giving simple articles, very simple articles to the students in groups, which they will be critically appraising and presenting, followed by discussion. Day 2 will be an interactive lecture on preclinical studies, which will include what are the basic concepts of preclinical studies, along with the ethical issues, the ethics, that is CPCA guidelines that we follow in the conduct of preclinical studies. Now, followed by this, what we thought is we will ask the students to review some pre-selected preclinical PG dissertations which are there in the department, and the students will start working towards the development of clinical protocols for these preclinical PG dissertations. So again, we'll be allotting mentors for them for this activity. Next, we have day 3. We will be doing a clinical trial. We'll have an interactive lecture on clinical trials, that is phases of clinical trials and various ethical issues, so that they get well versed there. Again, they know something about the clinical trials with what they have discussed in pharmacology earlier, but then this would be a more advanced discussion with various phases and also the ethical issues that are involved in in clinical trials. In addition to that, we also thought that if it is possible, we could have an interaction session with the experts from the pharmaceutical industry who could give an insight to the students related to career perspective in pharmaceutical industry. So we thought we could even reach out to our alumni who are in the industry who could help us with this session. Day 4 is we planned for a visit to the site management office for clinical trials in the hospital, where the students will be told about the process of ethical clearance for clinical trials. They will also be given an opportunity to interact with the staff there, as well as to go through all the standard operating procedures which are available at the site management office. Day 5 will be the presentations by the group on the clinical protocols that the students have developed on the preclinical dissertations that were given to them. So here we can say the students just randomly we can give each group, either one group presenting on phase 1 trial, another group presenting on phase 2 trials, and different type of trials. It is, and here I think our aim is not to see how accurately it has been done, but yes, our aim is to see that the students were actually involved in writing this and they have understood the concept. So we need to concentrate on that and not on the accuracy of the methodology that they have used. So day 6, there will be presentation of these clinical protocols, group presentations followed by group discussions. And as this is the last day of the elective, this will be followed by assessment, which will be we will be doing in the form of MCQs or any other exercises. In addition to that, there would be reflection and feedback. Giving feedback to the students on their performance, as well as obtaining feedback, which is very important for us because this is the first time that we could be implementing this, and therefore taking a very genuine and a sincere feedback from the students would really help us in improving the elective for the next time. So what are we doing for assessment? For assessment, yes, as already been mentioned by the NMC, this is going to be a formative assessment. Attendance, 75% of the attendance would be compulsory because this is an eligibility criteria for them to give their final year exams. The students in the beginning only would be told about how to maintain a portfolio, and therefore they would be encouraged throughout the elective to develop the portfolio. Plus we would definitely have a logbook, which is very much should be regularly maintained by the student. Then we would also assess them in various exercises that we are having during the course, like prescription writing, ADR reporting, and others. We would also assess their journal clubs. That is, this is the one which we would be doing in research, where we give them journal articles, very simple journal articles, and they would be asked to critically appraise and present that critical appraisal. So that also we will be assessing on a checklist, which we will be developing based upon the checklist that we have for our PGs. So we would be modifying that when we'll be using that checklist to assess them in critical appraisal of the articles. Also, we'll be assessing their seminar for their presentations and the group presentations based upon their preparation, their clarity of presentation and understanding. And as said earlier, at the end, last day, we would be having a theory exam, not a very exclusive one, but just to see how much knowledge they have acquired, maybe in the form of MCQs, prescription writing, or any other exercises which we feel appropriate, which definitely we have not totally planned on that still. We would also look into the reflective writing and yes, feedback. So this is the plan for assessment, and I think this is also a part which has been explained in the NMC also. Okay, Now, with all that, I'm sure when we look at the plan week wise and even day wise, when the plan is given to us, we feel that, okay, it's quite simple to present it, but it is not so. I'm sure all of you will agree with me that there are a lot of challenges which we are going to face in implementing. And now these challenges and the strategies to overcome these challenges are going to remain same for any of the electives that we are going to plan either for block 1 or for block 2. So from the perspective of faculty, what are the challenges that are anticipated? So we can see for faculty, the first one definitely is lack of complete understanding of the process. Yes, most of us have been trained in the CISP 1 and 2 workshops which are conducted by the NMC centers. But in spite of that, maybe most of us don't have a good understanding of the process and implementation of these electives. Definitely lack of experience, because this is for the first time that all of us will be working on the electives. We don't have first-hand experience on developing or implementation of electives. So this is one big hurdle. Next would be less number of faculty. I'm sure this is true with all the institutions. Most of the institutions have just the number which have been prescribed by the NMC. Lack of time, yes, definitely time is very important, because we need time not only to plan the timetable but also to plan the various resources which are required and time to implement. Lack of interest and attitude on the part of the faculty. We might come across some faculty who are not very much interested in implementing, and maybe we might not get the cooperation of such faculty in the implementation. So how do we overcome this? What are the strategies to overcome these challenges? So for faculty, we can conduct training as per the need. So as I said, most of them have been trained in CISP 1 and 2, which was just one session. So if we feel that still we are not very much confident of implementing at the college level, each MEU can definitely conduct one specific or one special training course, one special workshop pertaining to electives. Ensure adequate faculty. Now, this is not in our hand because it is with the administrators. But what we can do is we can also train our tutors which are there in the department who can be a part of this implementation. We can motivate the faculty by reward structure and academic credit points. I'm sorry, I cannot say financial credit, but yes, academic credit points can definitely be given to the faculty. And we can also seek support from other institutions if we don't have certain facilities at our institutions which are hindering the implementation of the program. So we can definitely collaborate with other institutions in the same place, because we need to understand in block 1 we are not sending the students outside as they have to attend clinic in the morning. So we can seek support from the institutions in the same place. Now, what are the challenges we could anticipate from the student side? Yes, the number of students that are available with us. Some colleges having 100, some 150, 200 and up to 250. So as compared to the global scenario, the number of students that are coming to electives at the time of choosing the electives or selecting these electives, we have a lot number of students and less number of electives with us. So limited number of electives. Now, why the number of electives are limited? One reason, as I said, is the number of the students that we have is too much. Second is because of the restricted resources that we might be having at our institution. And student may not get a elective of his or her choice. So this also might happen. Lack of interest on the side of the students, and some students may utilize this time for lost opportunities in learning. So they will start preparing for their next university exam thinking that they have time, but it should not be so. So how do we overcome these challenges of the students? Make as many as electives available as possible. So as I said, maybe with the restricted resources that we have in the institution, this might not be possible. So we can look out for developing partnerships with private hospitals and collaborations with other institutions, but in the same place. We can motivate the students with emphasis on the benefits. That's what I said. In the beginning, we need to emphasize what is the need for clinical pharmacology and what are the career opportunities that they have with expertise in clinical pharmacology. Make outstation electives available by fulfilling the prerequisites, but yes, this we cannot apply for block 1. This is only for block 2, but again with prior permission from NMC. Okay, so coming to the summary of the presentation, this is the take home message. I'm sure all of you will agree. We are right here now looking at, just looking at the electives with lot of things in our mind, with lot of suspicion. This is happening because we all are inexperienced. This is our first experience. We have lot of challenges and definitely we have limited resources. But I'm sure with the time to come, with the motivation, with lot of teamwork, team efforts, supporting each other and collaborations and partnerships, we will definitely reach a stage where we can successfully implement electives, and at the end of that we all smile. Okay, so we ourselves have to change from this look to this look. So that is when we will actually be successful. Okay, so that's all from my side. I would like to acknowledge the contributions of the Faculty of Pharmacology, JNMC, especially Dr. Anupama, who have helped me in planning this proposal, and also Dr. Sunita Patil, Professor of Pathology and Director, UDHP, who has helped me with the presentation. Thank you.
Thank you, ma'am, for sharing your experience with us. We shall take up questions at the end of the session on electives, ma'am.
Okay.
Moving on to our next elective, I would like to introduce Dr. Sachidananda Adiga, who will be sharing pharmacoeconomics as an elective. Dr. Sachidananda Adiga is Professor of Pharmacology, Shema, Mangalore. He has completed his MBBS from Karnataka Medical College, Hubli, and MD Pharmacology from Kasturba Medical College, Mangalore. He has obtained his certificate course in bioethics from Manipal University 2017. He is currently pursuing advanced course in medical education. He has a teaching experience of more than 20 years. He has more than 50 publications in national and international journals to his credit. His research interest includes pharmacogenetics, personalized medicine, and innovations in medical education. He is a recognized PG guide and PhD guide in pharmacology, Nitte University, Mangalore. He has guided 2 PhD students, currently guiding MD and PhD students. He is coordinator of Institutional Scientific Committee, Shema. He is University and Shema coordinator for NAC Criteria 1. He is member secretary of IAEC, Shema, member of Medical Education Unit, Shema, and an external member for Enapoya Ethics Committee 1. Over to you, sir.
Good afternoon, everyone. Thank you, Dr. Biasin, for nice introduction. And without much time taking in the introduction to electives, I'll move on to the electives which I have chosen. Okay. Dr. Nayana Madam had given an initial introduction to the elective. What is an elective? What are the objectives of electives and all? So I'll be, that has made my job more simpler. 1 minute. Okay, sorry for interruption. So I'll be speaking on, or we are sharing our experience in drafting the pharmacoeconomics, which we have, which we thought of having one of the electives for the coming batch. So first question is why we have chosen pharmacoeconomics as an elective? Because before starting anything, we need to address this issue, whether it is really needed or not. Okay, as we have been seeing this pharmacoeconomic evaluations, which are constantly being introduced or practiced in hospital setting, community setting, and also industry, and also it is being thoroughly used in various phases of clinical trial. It is very pertinent to use, or it is very pertinent to know more and more about these pharmacoeconomic evaluations. Then, what is the scope of this pharmacoeconomics for medical graduates? Why we need to have this elective, or why we need to teach, or why we have to think of having this elective for medical graduates? As we are seeing in the past few years, more and more MBBS graduates are directly joining to pharmaceutical industries. It is very helpful for them to have this as a background information. And not only those people who are going to pharmaceutical industries, as our services are well recognized in government sector, private sector, as well as we being the entrepreneur in some aspect, it is very, very essential to know various pharmacoeconomic evaluations. In that context, we thought of having or drafting this pharmacoeconomic evaluations, pharmacoeconomics as one of the modules. There is a well-known thing that is well beginning is half done. So whatever we draft as an elective, we need to plan accordingly. So these are the various steps which has been given by the NMC while planning and effective or implementing an effective form of electives. Okay, first and foremost, we have to define the learning objectives. First, we have to define the learning objectives of an entire elective. Then we need to identify the preceptors. We need to identify the preceptors or the facilitators who are responsible for guiding the students during this 1 month elective period. Then we need to prepare a timetable of various activities which are undertaken during this elective, and we need to list out or figure out the learning resources, and we need to share with the learner prior, and while doing so, we during the entire course, we need to be part of the team. Say, for example, 5 students may be allocated to one of the preceptor or 10 students. So we have to be part of the team so that we are also involved in immersive learning experience along with the students. Then we need to complete any prerequisites if at all needed to be completed before joining, because each elective is a different one. So if at all any requirement or basic training is required, so we have to identify those prerequisites, and we should see that the student completes that prerequisite and enters the elective. Then we need to define the various assessment, whether it is formative assessment or some other form of assessment, portfolios and logbook designing, everything should be kept ready, and it should be made available in the institutional website or notice board, and the student should have a free access to all these things. And in the end, program evaluation has to be done by the stakeholders, which I am not going to go in detail, because just now Naina madam had already spoken about the detailed evaluation thing. Okay, first thing is learning objectives. Learning objectives of pharmacoeconomic as an electives. So we have designed the learning objectives of the electives like this. So first, at the end of the session, the students who have been enrolled in this elective must state the need of pharmacoeconomic analysis. They should describe the different types of pharmacoeconomic analysis, either partial or full economic analysis. Then they should be able to distinguish the advantages as well as disadvantages of different types of pharmacoeconomic evaluation, and they should be in a position to perform independently a suitable PE evaluation, okay, for a given problem, and to apply the principle of pharmacoeconomics in various healthcare settings. So these are the learning objectives of the elective in total. So to render this activity, we need to have effective preceptors, or we need to have the full teaching faculty. We have an effective and well-experienced faculty, so that we can engage the students and we can guide the students as per the objectives which we have set before. Then, moving on to the next aspect of planning, that is preparation of weekly timetable. So this is very, very important step in drafting the any elective. So we need to identify what has to be taught and how it has to be taught and how it has to be assessed. So accordingly, this is just what we thought of teaching or having the timetable for the entire 4 weeks. So this is our timetable. In all the institutions, we may not get a similar sort of time, because some institutions it may be morning time may not be available, but as far as our institution is considered, we have 2 hours in the morning and 2 hours in the afternoon. So we have made the timetable like this. So in the first week, we are planning to have an introduction to pharmacoeconomic as a elective, and various perspectives of this, and we are going to give an overall overview of the entire 1 month training in this module. Then in the next session, we are going to have, or we have thought of devoting some time for types of various costs, and also we would like to have various types of interactive or group tasks in which they are going to identify the cost on the problem which we are going to share with them. Okay. Then comes various types of pharmacoeconomic evaluations. Basically, we are planning to concentrate on 4 important things, out of which we are going to concentrate only on the 3, that is cost minimization analysis, cost effectiveness analysis, as well as cost benefit analysis, because these are the 3 important type of analysis which are commonly being used in various healthcare settings. Okay, so to do that, we have designed some interactive, we have designed some didactic lectures and interactive sessions, group activities, followed by designing the protocol, and also we are proposing the students to take up projects also, which they are going to plan by making use of the scenario which we are going to share with them. Okay, so this is these are the various activities. I won't go into the details. It is already been displayed over here. So in nutshell, what we are planning is, apart from didactic lectures, we are planning to have the interactive sessions, group discussions among the groups, and also we are making them involved in writing the protocol, presenting the protocol, and also project writing. So this is as far as week 1 is concerned. And at the end of each week, we are planning to have one formative assessment, and they are supposed to complete the logbook which we have already designed, and also in the end of each week they are supposed to write one reflection writing thing. And also in each week we will be sharing one research which has been research paper which they are supposed to criticize. Moving on to the second, it mainly involves the second week. It mainly we are planning to have activities revolving around cost effectiveness analysis, and also we are planning to give some idea regarding how to write the project report, and rest of the activities will continue, like the lecturing sessions and interactive on group discussions, then designing the protocol, and the project, executing the project, and the criticizing the article with respect to cost effectiveness analysis. All those things will continue in the week 2. And in the week 3, we are going to mainly concentrate on the cost utility analysis, and some of the tools like which are commonly being used, like SF36 questionnaire, then decision tree model. All these things are, if the student know bit of these things, it becomes easy for them to build the knowledge subsequently. Then in the 4th week, we are planning to touch upon the cost benefit analysis, which is a bit difficult, but we are trying to give some idea regarding the cost benefit analysis. And in the 4th week, we are also planning to teach regarding the appraisal of article with the suitable time-tested guidelines, and also application of pharmacoeconomic principles in community setting, that may be in PHC or CHC, or the group discussion revolving around the same thing, and application of this pharmacoeconomic principles in hospital setting, so that they will have some hands-on training how to apply these principles in real-world scenarios. Say, for example, how cost minimization analysis can be applied in the PHC and community health center, and also with respect to small hospital setting, how best it can be employed. Cost effectiveness analysis, how best we can take up or decide the drug formulary. All those things can be touched upon in this session. And this entire session ends up after completion of logbook in each week, and also in the month end we are planning to have the e-portfolio completed. And also we are planning to take feedback so that it can be used in further strengthening our implementation of this elective in the subsequent years. So this is the various or how our activities are being planned across 1 month. And it is our duty to share the various learning resources in the beginning only, so that they can come prepared for various interactive sessions and also group discussions. So these are some of the learning resources which we are going to share with the students. And as I already discussed, this entire 1 month will be a sort of immersive learning or self-directed learning, in which we are just guiding our responsibility is to guide them, and also we are trying to make them, or we are trying to create a conducive atmosphere so that they can involve and take up or learn most out of, or they can benefit most out of this 1 month elective period. And also then, as far as assessment is concerned, it should be mix up of various types of activities. Like we had group activities in which they are supposed to present the paper case which we are going to share with them, and they have to come out with the answer. Their active participation has to be judged. Then protocol presentation and project work, for which we have made the checklist. So depending on their active participation, we can do the assessment. And also written test we have structured in the timetable, so that can also be made use in their assessment. Then online engagement, that is mainly in criticizing the particular pharmacoeconomic evaluation paper, so that can also be used. And as I said earlier, that formative as well as summative, even though summative assessment is not prescribed as per the NMC, just we can take up a call depending on the availability of time. Then logbook completion, reflection writing, as well as e-portfolio will form part and parcel of our assessment. So this is what I have already been discussed, just with the quantity of the frequent assessment which are coming up. Formative assessment at the end of each week. There are 8 group tasks, protocol writing for 3 evaluations. There are 2 projects and article evaluation, 3 article evaluation in 3 weeks. Reflection writing at the end of 4 weeks, at the end of each week, which constitutes around 4. Then logbook completion and e-portfolio will form the will complete the assessment session. Then program evaluation, as this is this concept has to be implemented. It has not been implemented so far. We are about to implement. So we never, even though we know what are the logistic, technical, and all sorts of problems which may arise in the due course of time, we need to have this program evaluation in place so that we can always improve upon when the next set of students lands up for this elective. Then I won't go into the detail of these things. This template has been given in the NMC. So just if you prepare and keep it, it becomes very helpful for us. Or if at all, if anything has been missed, we can rectify it. So as it has got various components like name of the elective, where it is being done, name of the people who are in charge of this, whether we need some external person as a resource person, all those things has to be known before only. And as we have already pointed out, the learning objective has to be specified in the beginning. And we should decide how much students we can take up to this particular elective, because it all depends on our teaching schedule, and we should also accommodate all the students so that we have to fix the number of students in the beginning only. So we thought of fixing 10 is ideal. We can go up to 15 for this particular elective. Then prerequisite, it is better if the students undergo a session on research methodology, which is being taken once they come to the second year or just before enter the final year. Then learning resources, which we have already shared. Then list of activities also that we have also shared already. And we need to identify and draft how the logbook should be, how the portfolio should be completed, all those things. And also we need to complete all the assessment well in time, so that we can complete the all the prerequisites well on 4 weeks, because they don't have time. In the next week, they are moving to the next elective. So everything should be structured beforehand. So this is all about the pharmacoeconomics as an elective, which we have drafted. We had made use of the COVID time in drafting in these things, but we have to tailor make these timetable and entire activity, because for this batch, I think this 2021 batch, we are going to have only 15 days, and probably for the 2022 batch entering the first year, we may get 1 month. So we have to redraft this activity accordingly. Thank you for patient listening. I think if at all any questions are there, we will take up after the next speaker's session. Thank you.
Thank you, Adiga sir, for sharing your experience in drafting elective modules on pharmacoeconomics. Now we have come to the last session in electives. And we have Dr. Mangala Rao, Associate Professor Pharmacology from St. John's Medical College, Bangalore. I would like to introduce Madam, who will be sharing with us pharmacovigilance as an elective module. Madam has more than 12 years of teaching experience. She has completed her advanced course in medical education. She has authored a chapter in Pendant's textbook of cardiology. She has various publications in national and international reputed journals like Nature and Lancet. Madam is a member of Board of Studies of Avichanchandgiri Institute of Medical Sciences, and her areas of interest includes cardiovascular research and medical education. Ma'am, the session is open now. You can take over the session.
Yeah, thank you, Doctor, and thank you. Shall I share my slides now?
Share your screen. Yes.
Yeah, thank you. I hope all of you can see the slides.
It's getting shared now. Just 1 or 2 seconds. Ma'am, can you hear me?
Yes.
Can you just
Yeah.
stop sharing and reshare the presentation? We're unable to see the slide.
Sorry, you want me to stop
Fine.
sharing? Is it?
No, ma'am. It's visible now.
Sorry. Yeah. Is this fine now?
Yes, ma'am. Yes.
Yeah. Thank you. Good afternoon, all. I'm the last batsman in So I hope to keep my presentation crisp because you know, a part of pharmacovigilance as an elective has already been covered. So let me just, yeah, so these are the objectives. We're basically looking at, sorry, I'll just minimize this so that, yeah. So at the end of the session, the participants should be able to develop a pharmacovigilance elective module for MBBS phase 3 students in their own institutions. So that's the objective. So before we get into it, as Dr. Adiga did, why pharmacovigilance as an elective? I think as pharmacologists, all of us are aware of these, numbers, which is the global burden, the global disease burden data in 2017, and these run in thousands. Even more recently, when people have looked at the pool prevalence of adverse drug reactions in a primary care setting, not even tertiary, they found that it was 8.32%. And more importantly, I would say there were around 12.3 to 37% of the ADRs were preventable. I think this is where we could make a difference by the students, because spontaneous ADR reporting is underreported. That's the main problem with pharmacovigilance in I think all the institutions for that matter. So in spite of these numbers, what do we find when we look at the medical training of our students? There was a systematic review and meta-analysis done about training in pharmacovigilance for pharmacy and MBBS students, and this is what they found. Only half of the students were even familiar with the terms like adverse drug reactions, pharmacovigilance, and the clinical relevance of pharmacovigilance. And very few, that is only around a median of 10%, showed that they were previously involved in reporting any kind of an ADR. And more importantly, this systematic review and meta-analysis brought out that the students found actual clinical experience, that is getting involved as a team member, to be more educational than lectures or even solving case scenarios. Because in our training, in right now currently the CBME training, we see that they already do this, do the exercise of identifying an ADR and reporting it on an CPSCO form. But in spite of that, this is what the students found. So this is about why pharmacovigilance is important, and what is the situation training in pharmacovigilance. So why did we at St. John's choose it? It was the pharmacovigilance program has been initiated since 1992, and we are a member of National Pharmacovigilance Program from November 2011, and we do have many publications, and we were a part of 2 ICMR grants, that kind of triggered these generation of these publications. So what are the pharmacovigilance related activities that we are involved in? I'm sure most of the institutions now would be doing this. That is the Department of Pharmacology. That is spontaneous reporting. Then we do collect adverse drug reactions from the wards. Then we are involved in adverse events following immunization reporting, which kind of became a regular activity since COVID vaccinations. Then the data entry in the VG flow. We do issue alert cards to patients in the wards whom, where an ADR has occurred. We give them an alert card so that they can take it away with them. And of course, the training of doctors, nurses, and clinical pharmacists with regards to pharmacovigilance. So right now the pictures are the activities that what we are involved in. The graph here shows one of the BG flow reports that we receive, the monthly reports of how many ADRs we have reported from St. John's. And the yellow box you see here are the boxes that are present in the wards in every nursing station. We have kept these boxes where they just drop in the form, and then we later go collect if further information are required. So since we have been doing all these activities for so many years, pharmacovigilance was a very logical to be given as for students. So at St. John's, we propose to do the learning objectives for our elective module. At the end of the elective, the student should be able to describe the significance of pharmacovigilance in a clinical setting, detect and conduct causality assessment of an adverse drug reaction, report the ADR in a CDSCO form from the ward, and of course, enter the data on WHO database, which is VG flow. Even though in UG teaching, they are kind of, comfortable with identifying the ADR and entering it on CDSCO, this will be kind of a revision for them and increase their awareness as they are nearing internship, and also the database that they can see now and actually enter the data. So moving on to the list of activities that we have planned for the students, they'll be trained on identification, collection, causality assessment, and reporting an ADR. Then they'll be assigned a specific ward. They are with us for 4 weeks. So immersive learning can happen only when they, really look at patients and the sheets there. So they'll be assigned a specific ward. They do collect ADRs and fill the CDSCO form, enter data on the VG flow database regularly, present a short report at the end of the posting. So these are the major activities, but I'll go into the timetable a little later. So what have we planned for their assessment at the end of 4 weeks? Of course, attendance is compulsory as NMC themselves have thing. They should have 75% attendance. Then they will have a portfolio, maybe logbook incorporated in it. We plan to create a single book, not two, where they do document the ADR cases that they have collected. We'll train them to maintain patient confidentiality. Of course, they will not be writing the names and the patient details here. Filled up CDSCO forms, and documentation of the presentation slides. This will be at the end, and then the report they have written after maybe 3 weeks of case collection and their training in Department of Pharmacology. So this is what the logbook or the portfolio will contain, and we'll see its completeness as one of the assessment points. So at the end of posting, they will have an MCQ based examination to assess the knowledge that they have acquired. But we plan to keep this to a minimum because knowledge is not so much, with the focus of the selective is not knowledge as much as, the skill. So if they could identify the ADRs and they can report it properly, then that carries more weightage. So this is our plan. So 4 weeks of posting. Ours is I would say, hybrid of Nitte and Belgavi, where we get 1 hour in the morning and then 1:30 to 4:30 in the afternoons. Between that, they do go for clinical postings. So 4 weeks of posting, then we have 2 sessions, and we plan to take around 20 students. And right now, the pharmacovigilance team has mainly to, if there are more students, the elective, in both the blocks, we may have students because we have 150. If the number of electives are not sufficient to repeat, that's what the talks is still on. So each faculty will find whom the to grant they're going to with the faculty on an assigned day. We have left it to the faculty's time and availability. So what do we plan? One, of course, election. Then we do plan to some amount of what is spontaneous reporting and what again how so activity that we have planned in week 1. So we are there in charge for to do it's to the war area. We do week this tag along in week 1 faculty and the PG or the juncture we're going to tell articles talk about pharmacovigilance and different in some week convert article present training competence we have but we'll have mentors to help out presenting these journal articles. So week 2 and week 3 are going to be kind of repetitive. Their afternoons they visit the wards, collect areas, enter of the form, and then they'll be shown the VG flows. They'll be entering their list. As I said, the third week will be they go to the over the line and in afternoons most last but an A of knowledge acquired in the of MC acquired simulated form and activity that's going to happen in week 4, even though one is we felt them to complete a research, but we do plan for them to do research projects and interest them, or kind of inspire them to take up development of project proposals and the way forward. So that is what the addition we are looking apart, the students getting excited about pharmacovigilance and completing the looking at these project posts. And we do expect an increase in spontaneous reporting when students, move forward as interns. If you are familiar, so this is how we have filled. I'll not go through this because that will be a repetition. So that was about our pharmacovigilance elective module of 4 weeks. And what you see there is our pharmacovigilance team. Dr. Padmini, who is the HOD, Dr. Suma, myself, and Shashi are the faculty there. The others are the PGs who are, working with us for pharmacovigilance in the department. So this completes my slide. Happy to take questions along with others. And I take this opportunity to thank Nitte for giving me this opportunity. Thank you. Thank you.
Thank you, ma'am, for sharing your experience with us.
Thank you.
And there are no questions for you in the chat box, but there is one question for Naina, madam.
Yes, ma'am.
What is the connection between pharmacology and artificial intelligence?
Okay. Yeah, I was just going through the questions in the YouTube and I saw that I was just writing down the questions which were there pertaining to me. And I saw one, yeah, there were 2 questions I think related to, similar questions which were related to artificial intelligence. As I said, actually just today morning when we were discussing this clinical pharmacology and of electives, one of my colleagues said we could think of artificial intelligence. But since there were some questions on this, I was just finding out, and as I discussed with a colleague of mine, there are a number of softwares actually which are available, which have we could have artificial intelligence along with the softwares, mainly for diagnosis, where the clinical as well as the non-clinical data of the patient will be available, and then that will help us to make some sort of diagnosis. That is one way. Second is there is also something which is called as the machine-based learning. Machines, in a sense, these are the mannequins which have been set up or planned or manufactured in such a way with the help of the software also that they can mimic the clinical features of certain diseases. Okay, and then based on that, the student, when he comes across these, he can just make a decision as to what is the clinical diagnosis, and also based upon the various parameters of the patients that are available, he can also take decision on dosing. Okay, selection of the drugs as well as their dosing. So I think a lot of it is still yet to come in artificial intelligence, but definitely we can make use of this. There's something also what is called as a virtual patients also, which is coming up. And actually in our high fidelity skill lab, we have a few mannequins which are like this, the virtual cases, as well as some of the mannequins which are already set to mimic certain clinical conditions. Now these actually we have in our high fidelity skill lab, which we are planning to use for our undergraduates. We have already planned a research protocol for that, which we will be doing for the next batch of CBME. So a lot of things are coming up like that with the help of the software as well as this machine based learning. Thank you. And I hope I have cleared that, because even I don't have much knowledge on that, but yes, few of these are available with us in our skill lab.
Thank you, ma'am, for taking up the query. Here we have come to the end of the scientific session. Now we request all the delegates to give your valuable feedback. The feedback link has been shared in the YouTube comment section. And certificates will be dispatched in 2 to 3 days after we receive the feedback. Now, we would like to call upon Dr. Ravichandra V to deliver the vote of thanks. Over to you, sir.
Respected all, we have come to the last stage of the CME. I am honored to propose the vote of thanks to all of those who have helped us in conducting the CME. At the outset, I salute our patrons, Sri N. Vinay Hegde, Chancellor, Dr. M. Shantaram Shetty, Pro-Chancellor, Sri N. Vishal Hegde, Pro-Chancellor of Academics, Dr. Satish Kumar Bandari, Vice-Chancellor, Dr. M. S. Muditaya, Pro-Vice-Chancellor, Dr. Alka Kulkarni, Registrar, Nitte, deemed to be University, Dr. P. S. Prakash, Dean, K.S. Hegde Medical Academy, Shema, Dr. Amrit Mirajkar, Vice Dean Academics, and Dr. Jayaprakash Shetty, Vice Dean Administration. Without these people's constant support and well wishes, CME of this magnitude would not have been possible. I sincerely thank the very knowledgeable resource persons of our CME, Dr. Raki Tripathi, Dr. Sheetal Ullal, Dr. Manikandan, Dr. Ananya Chakrabarti, Dr. Dinesh Kumar Badyal, Dr. Nayana Ashilkar, Dr. Sachidananda Adiga, MN, Sir, Dr. Mangala Rao, Ma'am. We are indeed very much enlightened with your valuable insights provided for effective implementation of CBME in pharmacology. The success of the CME should mainly go to the large number, nearly 300 delegates have registered, and we are thankful to all of you and inspired by you to do more such programs in future. A gentle reminder for our dear delegates to kindly fill the feedback form and submit by tomorrow 10 a.m., which will be useful for our continuous improvement. I also thank Manager of Shema Office, Mrs. Rachna, and her staff member, Dr. Sadhana Deshmukh, Director of Staff Development Cell, and her staff members, Mr. Mahesh Chauta, Head of IT Department and his team, Dr. Kishan Prasad of Medical Education Unit and his team members. Last but not the least, I would like to thank the members of the organizing committee of the CME, Department of Pharmacology, Shema, who are the driving force of the CME. Special thanks to Dr. Rajendra Holla, Head of the Pharmacology Department of Shema, who is my mentor, and Dr. Sachinanda Adiga, who is my teacher, for materializing his brainchild that is today's CME. I would like to express my sincere thanks to my colleagues, PGs, and non-teaching staff, Department of Pharmacology. Lastly, I thank each one of you who have contributed directly or indirectly and whose names might have been left out unintentionally. And I wish you one and all, and I wish you very wonderful evening. Dhanyawad. Thank you.
Here we have come to the end of the scientific session today. So I thank you all for valuable time that you have taken for joining us in the CME and making it a grand success. Wish you all a day filled with the goodness, warmth, and happiness. Feedback link has been shared in the YouTube, and it is also there in the YouTube link description. So kindly see the feedback link in the YouTube description. Your certificates will be dispatched only once we receive the feedback. So kindly fill the feedbacks by tomorrow morning, 10 o'clock. Thank you. So we will wind up the sessions. We will share the feedback link through email also. Any other queries? Thank you, one and all.